Maximize the screen. Maximize.
Maximize. No. Start my video. Start your video.
Good morning to all respected dignitaries, delegates, and all the members from various parts of our country. Our presence here today, it gives me immense pleasure to welcome all and multidisciplinary national conference on World Heart Day.
So to start with, may we arise and be one in mind, body, and spirit as we praise and thank our Almighty God for all His grace and blessings through the doxology.
There are no adjectives we can use to describe how awful and painful in the heart disease is. Unfortunately, the heart is as created an experience that is unlikely to be forgotten. This is very natural but unwanted, as we all know cardiovascular disease accountable for all known communicable disease deaths.
The voice is not there, please. The voice is not there.
Making its world number
There's
one.
no clarity in the voice.
Making its world number one killer, World Heart Day, therefore, perfect platform for the cardiovascular disease community to unite the fight against cardiovascular disease and reduce the global disease burden.
Nothing can be more assuring and heartwarming than affectionate word of welcome our beautiful, hardworking organizing chairperson and principal, SB College of Nursing, Professor Sneha Borgai, to formally welcome us and let us lend our ears to ma'am.
Respected dignitaries, honorable chief guests, speakers, delegates, members of management, and invitees. I am indeed happy to have a pleasant task of welcoming this gathering for the gracious occasion of a multidisciplinary national level conference through virtual platform on World Heart Day, with a theme Cardiovascular Health for Everyone, in the proud history of SV College of Nursing, Bangalore, a unit of Little Flower Group of institutions. In association with DNIP Care and our sister concerned institution, Little Flower College of Nursing, Bangalore. I, Professor Sneha Borgai, organizing chairperson of today's conference and principal of SV College of Nursing, is here representing our institution with full of hopes and pride to welcome you all. There is no achievement without the grace of God. Yes, nurses today have made considerable advances in their professional standing, supported by extensive university training, expansion of skills, and gradual taking over of responsibility. To begin with, I warmly and respectively welcome the chief guest of today's conference, Dr. M.K. Ramesh, Vice Chancellor, Rajiv Gandhi University of Health Sciences. To introduce Sir in brief, Sir has a vast and varied academic and administrative experience in the domain of medical education. Sir was a senior professor in the surgery department in the prestigious Bangalore Medical College and Research Center. Earlier, he served as registered evaluation in Rajiv Gandhi University of Health Sciences. Before his appointment as Vice Chancellor, Sir was serving as President of Postgraduate Education Board of National Medical Commission under Ministry of Health and Family Welfare, Government of India. He has a postgraduate qualification in surgery. Sir was awarded a fellowship by Royal College of Surgeons, United Kingdom. Likewise, Sir has boundless achievements and awards adding to his credits. Sir is expected to have a far-reaching impact on the quality of healthcare education at university. Presently, Sir is in a distinguished position as Vice Chancellor, Rajiv Gandhi University of Health Sciences, Bangalore. It's our privilege to have Sir amidst us. Your presence has rejuvenated us, and on behalf of our entire nursing team, we extend a very warm welcome to you, Sir. I request Sir to give away an inaugural note to all our delegates on World Heart Day today. Over to you, Sir.
SV College of Nursing that is holding World Heart Day. And hello, namaskara. It's a great initiative by SV College of Nursing.
Not audible, please.
Heart Day. And in fact,
Sorry, cannot hear.
Present situation. People are stressed. Our lifestyle has changed. Food habits have changed. Because of this, hello, namaskara. It's a great initiative by SV College of Nursing that is holding World Heart Day. And in fact, it's relevant in the present situation. People are stressed. Our lifestyle has changed. Food habits have changed. Because of this, actually, a lot of pressure is being put on the heart, which has resulted in many patients with high blood pressure, heart diseases, and India is becoming the capital of diabetes in the world. In this background, it's up that people are exposed to the perils of the lifestyle change. So in this occasion, I wish SV College of Nursing all the success and for this function, and wish everybody a happy learning. Thank you.
Thank you, Sir, for the wonderful inaugural note to our delegates. A presence of dynamic personality make the session captivating. I am glad to introduce a person with experience and expertise with a tremendous knowledge in healthcare industry. We feel honored and proud by her distinguished work in numerous capacities. I extend a hearty welcome to Professor Dr. Bimla Kapoor, Chairperson, Committee of Experts, National Nursing and Midwifery Commission, Bill 2020, former Director, IGNO, to this event to introduce brief about Madam. Madam hardly requires any introduction as she is well-known personality in the healthcare industry who has rich experience in nursing pedagogy, administration, research activities, and so on, spanning more than 4 decades. Few career highlights to mention about Madam are: Madam established Delhi Nursing Council and served as the first president of Delhi Nursing Council. She published her first book on psychiatric nursing by nursing author in India. She served as a first director of IGNO Health Sciences and was awarded first PhD degree from IGNO Open University. Madam was the first Vice President of Trained Nurses Association of India. Other contributions of Madam includes: Madam trained several short-term courses on research methodology and health assessments from World Health Organization, added with several core competency skills on various specialized areas related to healthcare and human relations. Adding to her credit, Madam has innumerable
Ma'am, you are not audible. You are muted, ma'am.
Few credits about Madam to mention are: she holds President Gold Medal for MSc Nursing program from Delhi University. She was awarded WHO Fellowship as from Bangkok. She was recognized as a first Indian scholar and was awarded with NHS 50th Anniversary Fellowship from British Council, United Kingdom. She was awarded as a Research Board of Advisors from United States of America, and many more to go. We are honored and proud to have such an eminent personality in our midst, and we offer a heartily welcome to you, Madam. I request Madam to give away a keynote address to our delegates on World Heart Day. Over to you, ma'am.
Thank you, Professor Sneha. Thanks a lot for giving such wonderful introduction. Well, it's always a pleasure to listen to the upcoming people and also knowing their contribution made in the nursing profession. So we feel really delighted to know that how the things are progressing so very well in all parts of the country, and proud of you also. Dr. M.K. Ramesh, Vice Chancellor, Rajiv Gandhi University of Health Sciences. Professor Sneha, Principal of SV College of Nursing as a unit of Little Flower College of Nursing. Mr. Hamza, who is the General Secretary, DNIP Care. Program Coordinator, Mr. Suresh, who is really very active. Eminent speakers for the sessions on cardiovascular health for everyone and palliative care. Invited guests, very dear participants, and very, very dear students. Let me congratulate the principal, faculty, and management of SV College and Little Flower College of Nursing for organizing the multidisciplinary national level conference in association with DNIP Care on World Heart Day. Nothing can be better than what you have planned, remembering the role of nursing personnel in preventing the heart problems on this World Heart Day, very similar to health. Huh? Okay, I am sure you all have read it, you all know it, that World Heart Day is celebrated every year on 29 September, and it was created by the World Heart Federation. It's available, the data is available. It is basically aimed on informing to people around the world about the cardiovascular diseases, help people to fight against CVD problems, and also inspire others to see that you are able to go for such kind of investigation and checkups that you are not, you can be prevented from getting the cardiovascular diseases. And also it encourages the heart healthy living, which I think all of us, we need to have it and we all deserve to have it if we take precautions. The main concern and focus emphasized is on the prevention, treatment, and management of cardiovascular diseases worldwide, which reflects in the theme by the World Heart Federation this year, cardiovascular health for everyone, may it be child or the old age person. It's the cardiovascular health for everyone. Even though, cardiovascular health has been a concern for every living being in the world, still it has been overlooked by people. They are aware of the fact, as mentioned by Dr. Ramesh, people are aware of the fact that hereditary conditions, lifestyle, lifestyle problems like smoking, societal and environmental factors like air pollution, sedentary work, also the different kind of stresses, everything is known to the people. The stresses are physical, the professional like working from home, or pandemic facing like COVID-19. All these stressors are there, which they play significant role on the physiology of the body and more so on the heart or the cardiovascular health system of the individual. But still, people do, people get into unhealthy lifestyle like tobacco taking, use of harmful drugs or alcohol, not able to manage the lifestyle. So the effect of the behavioral risk is so tremendous that the people land up into the cardiovascular disorders, especially when there's a raised blood pressure. People start taking the medicine as prescribed by the physician or by the doctor, but just does not go for the other kind of checkups like diabetes, like heart problems. And this becomes a really very important factor to lead into cardiac failure or complications or cardiovascular diseases. So cardiovascular diseases are as mentioned, is the leading cause for death globally. Taken an estimate of, I think, 17.9 million people who are dying every year, and more than 4 out of 5 CVD deaths are due to heart attacks. And that's a very, very alarming thing. Of course, it does include the stroke, but then it does culminate to that the blood supply to the brain is not going. 1/3 of these deaths occur prematurely in people under 70 years of age. We are really getting alarmed of losing young people due to sudden cardiac attack, cardiac arrest, heart attack, 40 years, 45 years, 47 years. And that's becoming very painful for all of us because of the type of lifestyle these youngsters are going through, because most of the people do not go for preventive checkup. And let me also share with you, I hope Dr. Ramesh is listening to me, that many of the people who are, many of the health professionals, if they go for a health checkup, the colleagues, the doctors would say, why do you need to come for the health checkup? There's no need. And the relatives will say, or the wife will say, or the husband will say that I'm not worried, but she or he is over anxious to get my yearly checkup done. So I think these kind of attitude we need to really give off, because we need to take anybody who's coming for preventive checkup, that serious examination is required to be done on certain aspects, especially the diabetes, the stroke factors, the blood pressure, and the cardiovascular disorders. Because many times people don't go for this, preventive checkup because they say, suppose, I don't know that I have CVD, but suppose I am diagnosed and I have, thinking of that only, going for preventive checkup may lead them to insomnia, may lead them to restlessness, or may lead them to depression, that should I go or should I not go? But if it is made mandatory, I have seen that some corporate, they say that within 1 year, you have to go for checkup and report, and it is on the expense of the company. But still people don't go. They keep postponing, till the time alarm comes to them that the year is ending up. So those are some of the very important things that, the government or the individual themselves or the private sector, they insist on that you go for your annual checkup. And this needs to be taken seriously. To me, I feel the packages are very, very expensive. And to help, I hope the World Heart Federation, we looked into it, that these packages should be made simpler and less costly so that the people can go for these kind of checkups, because otherwise they are very expensive. And in the government sector, it is very difficult for people to go for these kind of preventive checkups, because the government is overloaded with the government hospitals are overloaded with the work. It's only, once you feel uneasy, you say, let me go for checkup, whether it is government or private hospital. But then, we know that the preventive checkups are hardly being done in the government hospital because of the overload of work to the doctors, nurses, and all the health professionals. So I think the World Heart Federation has to strategize these kind of things also, to see that the people are able to go for these kind of heart checkups. To me, I think as nursing professionals, we have a very significant role to play. Now, it is at the promotive level, preventive, therapeutic, as well as rehabilitative level. Because we as nurses are the major professionals who are who are in touch with the community as a community health nurse, and who are in touch with the hospital, the relatives of the patients 24/7. So this workforce, the nursing workforce, we as nursing workforce have got a very important role to play. Like at the preventive level, also the nursing professionals work from the perinatal period to the end of life. The perinatal period, when the women come with the swelling of feet, you check up blood pressure, you check, and oh my lord, the blood pressure is high, let's go to the cardiovascular checkup and all that. So all those initiatives taken by the nursing professionals are very, very important and significant to contribute to the World Heart Federation thinking of it, making a nursing professional as a core member of the World Heart Federation. I wonder if they have some, because I haven't read anybody anywhere that the World Heart Federation also has a nursing members who can contribute a lot. So at a promotive level, I think the nurses, along with the other healthcare workers, can educate the community, can educate the young boys, can educate the people who work under stress, can also, because stressors are like in the private sector, there are deadlines, there are targets to be met, and that's a huge burden not only for the individual but also for the families. And of course, when you are organizing as nursing professional the health talks, it has to be contextualized into that local areas, culture, and society, because we cannot keep on talking of bookish knowledge and bookish symptoms and all that. If there is a stress or a burden during the cultivation, what kind of stress is there? Is it a money? Is it a human resource? Is it getting a tractor? Or if you're working in the urban community, what kind of stressors are there? And it has to be contextualized. The health talks are to be contextualized as per the time, culture, and society. And of course, in the language which they understand, because also we can tell them that how physical activities help you, and physical activities are very, very essential. It's very difficult to move people for the physical activities. You keep on struggling saying, but the people don't listen. But repeated enforcement probably will help some, if not all. Out of 100, if 10 are helped, that means 10% you are preventing the heart attacks or cardiovascular disorders. So, and that's a big achievement if you can do that. And of course, at preventive level, that was promotive, but at preventive level, regular health checkups can be arranged, camps can be arranged. For me, it is very, very important, in a college, if you are a community health nurse, catch hold of a union person, and you tell the union president or the college union president, let us do the health checkup, all the boys and girls, and if you want the teachers, the other workers who are there in the college, and that will be very successful. Also, very important is CPR. I just want to share an example with you that there was a nursing teacher who was traveling from Delhi to Nepal, and she found that there was a announcement in the aircraft, isn't in doctor around, the person has fallen down. So this girl, this tutor, she ran forward and she said, I am not a doctor, but I am a nurse, but I know that what I have to do. And then they said that we cannot allow you to break open the emergency kit And she says, no, you have to break open the kit. If not, I am also a wife of a Air India personnel. So she got it broken and she took out the, cardiac pressor. And she gave us a CPR and cardiac pressure and she revived the patient. He was a huge Sardarji. Patient went to Nepal and he was all right, came back, wanted to be in touch with this teacher, but she said, no, I've done a part of my duty. I don't need any kind of favors, any kind of announcements, any kind. I mean, that becomes a skill. A skill is very important. Each one of us, we need to have a skill and we should teach this skill to everybody. Now, at the therapeutic level, of course, as a nursing professional, you need to intelligently carry on the nursing procedures by and therapeutic intervention like medications. And whatever medications are to be given, knowing the side effect of the medication, educating the person about regularity of the medication, also telling them that what can happen if you take on miss the dose, if you don't miss, I don't take on time, So those kind of interventions are required intelligently, evidence-based, and also, that how the heart rate gets changed when the medications are not given, and what will happen to the patient, what happens to the urine output, what happens to the body of the patient. All this we need to help the patient to know it at the therapeutic level. Of course, at rehabilitative level, people think now we are all right, we have got angioplasty done, we don't have to be bothered about it. My heart is strong enough, good, strong is heart, the heart is strong enough, but the follow-up is very essential. Whether you are working as a community health nurse or a hospital nurse or an OPD nurse or anybody, anywhere in the health system, you need to really educate the population for the, follow-up. For me, the element of nursing care for the heart patient will be a good listener. Listen to the patient's problem. Whenever patient says that, oh, I'm uncomfortable, just don't ignore it. Uncomfortable can be because of the anxiety. It can be because of some other problem. It can be because of the stress. But the moment the person has said uncomfortable, you need to talk in detail, listen to the patient, why the person is uncomfortable, and allow the person to talk about it. Also, communication with the patient and relatives is very important. Especially communicating the diagnosis, communicating the prognosis, of course, at the level of understanding of the patient and relatives, but it should be also within the protocol of the hospitals. Because some hospitals, they talk about diagnosis and prognosis together, and once they have decided what they have to talk to the relatives and the patient, that protocols need to be followed. Symptoms assessment, making nursing diagnosis, planning intervention, implementing the intervention and evaluating. If the patient was very restless, my helping to the patient to sit in a Fowler position or starting oxygen has reduced the, has increased the level of oxygen or not, or also has improved the patient's breathlessness. And by the time you inform to the cardiac surgeon or cardiologist, at least these intervention at the nursing level, starting the oxygen, maintaining the oxygen level, checking the vital signs, maintaining the blood pressure, these things can be done as part of nursing intervention, because that's what is significant. Giving evidence-based nursing care with empathy and passion. Very important. Empathy is the one which the patient needs that time. And if you can empathize with the patient and the relatives, you'll find, the tears rolling in the eyes of the patient, Why? Because patient thinks, here is a nurse who understands what I'm going through, what my family is going through. That stands true with the palliative care also, because it's not only cardiovascular disorders, but in the palliative care also it stands true, how empathetic and compassionate as nursing professional, as human being, we are to the other human being is important. Psychosocial support to the patient and family members, the patient is lying down on the bed, no problem. Patient is getting the treatment. Patient doesn't even know what's happening to him or her, But the relatives are pacing up and down. Just go out, hold a hand of the relative, make them sit, see that they take a cup of tea, tell them you can rest down for some time. I will come and inform you, as per the protocol of the hospital, how is the condition of the patient. It's more than enough. So encouraging a follow-up is another very important thing. So dear friends, the things I am sharing are not something new for all of you, because you all know this, or you can go through, Google and see everything on that. And this is your routine work, which I'm talking about. But you know what happens during this routine work? We still miss small but very significant activities of hand holding a friend or a person who is going through a stress, or listening to a person who is really in depression and wants to confide in you, but you don't have time to listen, or taking over the task of a nursing colleague who is just not well, or changing the duty of a nurse who is showing the symptom of burnout syndrome. We don't get time because we are so busy. And that's where we miss an opportunity of really taking care of a person and listening, hand holding, and seeing that the person doesn't go into the serious problem. It can be a heart problem, it can be a mental breakdown, anything. We also need to understand the mental well being and mental health of our patients, their relatives, definitely of our nursing colleagues, team members, and workers. Because cardiovascular heart awareness does describe all these aspects too, even though they are not said very loudly, but we know that everything is getting affected because of the mental health. If the person has good mental health, will be able to cope up the stresses, will be able to cope up announcement of cardiovascular problems. So mental health, mental well-being is also to be taken care of. As core team member of the health team, it is very important that we keep upskilling ourselves, updating ourselves in knowledge and skills, and be passionate about the care we provide to the clients, as they are not just clients. They are, important and a very significant family members in their family, in society, and community. So let us join hands together and pledge that we will keep updating ourselves in prevention of cardiovascular disorders, and also look after the people who are going through us in the hospice or at home for palliative care. We will use our knowledge, we'll use our skills to provide mental health care to these patients also, relatives, and our healthcare team members and nursing workforce. With these few words, let me thank the SV and Little Flower College of Nursing and DNIP for inviting me to share my thoughts. God bless you all with a healthy heart, full of love, care, and passion. Thank you so much. Thanks.
That was really an inspiring and thoughtful words. We value and respect your opinion about nursing profession, dear ma'am. Thank you so much. Next, we have with us Mr. K.V. Hamza, General Secretary, DNIP Care. To introduce Sir in brief, Sir was graduated from Kerala. Sir is a retired Senior Accounts Officer, Ministry of Finance, Government of India. He conducted several sessions on palliative care across many countries, which includes University of California, Riverside, United States of America. Sir was associated in palliative care as a volunteer and further a General Secretary for DNIP Care, which is a registered volunteer organization for palliative care since the year 2008. Sir also received KMCC Social Service Award and many more achievements adding to his credit. We are honored to have you with us, sir. On behalf of our nursing team, I extend a hearty welcome to you, sir. I request Mr. K.V. Hamza, sir, to take over the session to give away a keynote address to our delegates.
Sir, you are on mute. Please unmute.
So
Thank you.
thank you very much, ma'am. And good morning to everybody, all the participants. And this is a really good opportunity that we are sitting in this national capital territory of India. We are able to communicate with the students there in SV College of Nursing and Little Flower College of Nursing. Because nurses, when we say nurses are there when the first breath is taken. And nurses are there when the last breath is taken. So, ma'am, Sneha ma'am was telling that healthcare industry. I would like to slightly say, let us not say it's an industry. Can we just say health sector? Because when we say that industry, then all the bad elements attached with the industry, that also creeps in. So this healthcare, or even in public health, the nurses, the role of the nurses, that is much more important than from the first sentence that I told, that it is on the first breath and last breath, nurses presence, their presence are there. And in addition, and the distinguished girls, just like Dr. M.K. Ramesh, the Honorable Vice Chancellor of Rajiv Gandhi University of Health Sciences, and Professor Dr. Bimla Kapoor ma'am. Bimla Kapoor ma'am is always what we can say humsuffer with this DNIP care, because whenever we hold any program somewhere near East Delhi and all, she on just an invitation from Suresh sir, she is there to help us. She is there to talk and deliver her thoughts to the not only the nurses but also the community as a whole. Because after all, nurses, they are having their role and all. But what about considering them as an individual, as a sister, as a brother, as a daughter? When they hook up their white coat, they are also part of the common people like me. Because I was just thinking of with the luminaries, these kind of dignitaries, among them, what is my role? That I was just thinking of, especially in this World Heart Care Day. So World Heart Day, I shall say. So if health say it is not on the academic side, not on the therapeutic or on all other sides, but at least ma'am, when ma'am was talking, that Bimla Kapoor ma'am was talking, I was just thinking that she's telling all the things to me just because I am a defaulter and ended up with the 3 stents. So the checkup, preventive checkups, that is essential for Government of India. I was working in the Government of India. It was essential. Still, I was not getting the time for going for that till I got admitted for a procedure. So this is an essential thing. Now I can say from my own experience that this is an essential thing, and this needs to be enforced. Along with that, ma'am was talking about all other things also, but just few thoughts I'll just share here. And then all our distinguished faculties are also there. And ours is DNIP Care, or the Elites National Initiative in Palliative Care, where we are established way back in 2008 as a community-based palliative care unit, comprehensive palliative care unit. So we have established it starting with the home care, and then associating with the hospitals, and trying to provide whatever feasible within our means. That is the cost within our means. We cannot do everything. We cannot do what are all, especially there's even for preventive checkup, ma'am was talking about it's a huge cost. Then what to say about the treatment option? So many patients are there, they cannot afford any kind of treatment, and the long queue in the public sector hospitals, it is beyond imagination. So that is one thing. And the other thing I would like to say is, ma'am was talking about CPR, basic life support and all. Is that it's not only for nurses or the medical professionals, it has to be imparted to everybody. Every college student, every school student, maybe senior secondary schools or secondary school students, they should be taught this CPR, where whenever there is a requirement, they should be able to act upon. So that if the authorities, just like Dr. Ramesh sir, if he is available here, and people like him, he can take these kind of thoughts to its logical conclusion with the government agencies and all. And just to introduce a topic on this CPR, or even we can say even on palliative care also. If I'm belonging to the Kerala state, and if we go and ask even a small child, he might have heard the palliative care word. But in contrary, if we go to the Nirman Bhavan, where the Union Health Ministry is situated, there may not be more than 5% of the officials manning the ministry knowing about palliative care. So that is a scenario, Indian scenario, I would say. So in this, the role is much, and I'm not supposed to speak on all these kind of things and all. So of course, diabetics and all, everybody was talking. It is 21.4% of the prevalence of CAD is of 21.4% for the diabetics, and 11% for non-diabetics. And the stress, that is always there. And stress, we will say that we can avoid stress, but stress, each individual stress, no individual stress, then the relationships, ego clash, professional or work-life balance, or lack of communication, all these things, in addition to what we can say, the food habits, sedentary lifestyle, alcohol, tobacco, and of course, hypertension. So all these things are adding up. So I would like to request our speakers, just like Dr. Angur Chikhara is the assistant professor of Vardhaman Mahavir Medical College and Safdarjung Hospital, and Mr. C. Deshant is also the he is a nursing officer and the trauma nurse coordinator. These people are there. They are to talk about cardiovascular health for everybody. So just Dr. Ankur Chikhara, I had an interaction with him only once, maybe for half an hour or 1 hour only. But thereafter, I was just seeing, in addition to his duties and responsibilities in the hospital, he's also very much available there on the social media, wherein he's putting in the videos, how to do your diabetic charting, how to do other things and all. See, this is the real individual social responsibility, the kind of people they are able to discharge. So even now, Mr. Deshant, C. Deshant, he's a nursing officer. Yesterday, he was there with me for doing a day before yesterday, for doing a catheter for bedridden patient who is bedridden since last 2017 onwards due to hemorrhage, due to hypertension and hemorrhage, and he is totally paraplegic now. So all these people, and then what to say about other luminaries, rather, I'll say they are the Dr. Bableshawar and Ms. Alice Stella Virginia, ma'am. They are the stalwarts of palliative care. So let us, before my blah blah too much, let us invite Dr. Ankur Chikara, Assistant Professor of Vardhaman Mahavira Medical College. And
Sir, let me interrupt. I will just give an introduction about sir. Yeah, thank you. So that was really an inspiring words. Thank you so much. Thank you so much, sir. It's not working. Sorry, it's not working. Even work up. It's not working. Yeah. Yes. Next, thank you, Mr. Hamza, KV Hamza, sir, General Secretary, DNIP Care, for your thoughtful words. Yeah. So next, we are going to start with our session. So before we begin, yeah, we have our eminent speakers for today's first session, Dr. Ankur Chikara, MBBS, MD, Assistant Professor at Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. To give a brief introduction about Sir, Sir has more than 8 years of experience in the field of internal medicine and has been widely acknowledged for his versatile and patient-centric approach. Sir is a gold medalist in his MBBS and MD medicine, graduated from prestigious University College of Medical Sciences and Guru Tegh Bahadur Hospital, New Delhi. He worked as a senior resident in the Department of Cardiology at Janakpuri Super Speciality Hospital, New Delhi for a couple of years. Currently, Sir is a consultant in the Department of Internal Medicine at Safdarjung Hospital and a remarkable role in leading SARI, severe acute respiratory infections, monkeypox diseases, and many more. He's also been trained and specialized in several certifications like liver and cardiac disorders at ILBS New Delhi. Sir has published more than 20 national and international publications in medical journals. Adding to his credits, other than field of medicine, Sir is a renowned poet, writer, and a novelist who has given a beautiful narration of life, which states, "You have a life which is provided to you only once. So live to the fullest and be in constant search of true purpose of, of the existence." So beautiful, sir. We are extremely grateful to have you with us on this event. I request, sir, to take over the session. Over to you, sir.
Am I audible?
Yes, Dr. Ankur, you are audible. I'll be sharing the slide for you, Dr. Ankur.
Please let me know when you want me to change.
Can I take the control of changing the slide by myself?
Yes, definitely. Why not? Yes, I'll do that. Yes, you can please try to share those slides yourself. Try doing that now. Let's see if that works.
No, I'm not able to.
Please try one more time.
No.
I have given you the co-host rights. You should be able to.
Should I share my screen?
Yeah, you can share your screen and your slides. Either ways. It should work. I'll stop mine. You try now. Yeah, perfect. Control F5. Yeah, that's fine.
My screen is visible to all.
Yes, yes, doctor. It's visible.
Thank you so much to all of you to have me here, and it's a great pleasure and honor for me to be here to speak on the topic cardiovascular health for all. Myself, Dr. Ankur, working as assistant professor in Deshant Hospital, and very thanks to start my speech on the topic. First of all, to KV Hamza ji from DNFI Care. Thank you for bringing me here and all the team. And secondly, to the SV College of Nursing and team. Today, we are celebrating the World Heart Day, and we usually celebrate the same day on repeat multiple days just to make people more aware about what exactly heart disease or any other disease which related to the cardiovascular term presents to you, how it presents, how usually it's like trouble you somewhere in your life. We should be aware about the part that cardiovascular term doesn't only mean that it is a disease related to your heart. It may be related to some blood vessels which are supplying the heart one, supplying your brain area, or present in anywhere, any other in the part of the body. So any disease related to the blood vessels and heart are considered under the category of cardiovascular health disease. And today, we are not just celebrating the World Heart Day, we are actually trying to aware the people on what other ways a person can get a disease secondary to your lifestyle, your diet, your lack of exercise in your lifestyle. So to start with, to give you an alarming number that most of, just leave that part, 17.9 million lives each year are being taken by the cardiovascular disease. A very basic point that most of the world, more than half of the population in the world is actually being suffering from any one of the cardiovascular disease. It might be heart attack, it might be stroke, it might be smaller stroke that patient is not paralyzed but is having memory loss, or it's patient is maybe having some kind of disabilities in the form of not able to do some functions. It may be blockage of some vessels in the peripheries which may cause some kind of amputations and loss of the limb, and it may cause damage to the fingers or one major part of the knees joints. What is happening is, to begin, you should know what exactly your heart is doing. At this point of time, I would like to bring your attention on the point, like if you know some language, if you know Hindi or English, then you can enjoy the perks of that language, like in the form of music, in the form of, even if you are into some gossiping kind of thing, then you can understand the gossip only when you understand that language. And your human body is being designed in a very beautiful way that your body doesn't want to die. Even if you do the worst with your body, but your body will try to prevent you, and it has a different signs and symptoms kind of a language, which if you know, then you can prevent yourself from getting a one particular kind of disease. And it is true for every kind of disease which we know till date. So true for the heart part. And earlier you react, the better result you will get, the lesser expense you will do on your health, or particular to that particular organ. So being aware, being what we are doing right now is we are just trying to make you sensitize about that silent language, which is actually, if you can pick up those points, then you can understand that something is going wrong in my body. And then if you know how to correct that part, you can live a better, healthy life, and probably you will not get disease related to your cardiovascular health. And to your surprise, today we are getting people of 26 and 27 years of age having heart attack, having some kind of brain stroke, having some kind of limb and amputation secondary to some blockage of the vessels, all secondary to the poor lifestyle they do, secondary to the drug abuse, substance abuse they do in their life. So I want you to be aware of that silent language which your body gives to you, silent signs, silent symptoms, that now you should be aware, and now you should be aware about those parts which you should do to correct those wrong habits of yourself. So to begin, your heart has 4 chambers. We all know that since it's a nursing seminar, all of them must be aware of the anatomy of the heart and how the deoxygenated and oxygenated blood is being circulated in the heart. Important point is, few are the arteries which supply the heart from outside, from inside. We have the 3 layers of the heart: endocardium, myocardium, and pericardium. And what is happening is, whenever there is blockage to the circulation into these particular layers, your heart gives a sensation like that pain, which you call it angina. And what angina is, particularly a pain which is happening over the chest, particularly on the left side, but that doesn't mean it remains on the left side. It can be present on the right side too, but it's atypical presentation. Mostly it is on the left side, radiating to the left arm on the medial aspect. But where else it can go? It can go to your epigastrium, it can go to your jaw, it can even go to your right shoulder or left shoulder. So any pain which is occurring when you are doing some kind of exertion, and it is going when you are taking rest, it is associated with diaphoresis, excessive sweating, shortness of breath. You are not able to, you may be having the blackouts at that particular time. It's angina. And why this is happening? It is happening due to poor circulation in these coronaries, which you are seeing over the heart. And at this particular point of time, again, the same line which I repeated before, let me say that part, your body tries to save you. So this angina usually occurs when there is more than 60% of the blockage of the diameter of coronaries. That means up to the 60%, you must be having some kind of symptoms in the past, some kind of signs. If you must have picked those particular signs and symptoms, you might not get into that condition that now you are having angina, right? So it is more important that you should know something about your body, your particular organs, how that organs react when some damage to that part. Like in this picture, you can see if there is partial obstruction, you get an ECG done, and you will get some kind of ST depression. But if there is a blockage almost 80 to 90%, what you will get ST elevation. That means what? If you are getting ECG with more of the ST elevation, that is more significant, and it has to be acted at that particular time. But if you go for the preventive checkup in, say, in the yearly basis or 2 yearly basis, and you are getting some kind of ST depression in your ECG, you get you should get an alarming sign in your mind that yes, I should get evaluated myself for something else. There might be some obstruction in my heart. If it is there, I should focus on the lifestyle which I should follow, so that I will not go into the state where the complete obstruction will be there, and now there will be ST elevation. And ST elevation, all the medicals know that ST elevation is a significant kind of an MI. MI means myocardial infarction. But we don't pay attention to these minor changes. Why? Because we have a stigma in our mind that these checkups are too expensive. But tell me one thing. Today, if you go to any food outlets, any good food outlets, how much you end up in spending if you even go for a coffee or something? It is usually more than $500. But if you go for an ECG for a yearly basis, it will cost only 200 to 300 rupees. Even if you go to the government hospital, it will cost you only 10 or 20 rupees. The only cost is your travel. You should go there, get in the line and get it done. But we don't want to be in the line. We don't want to spend the money, but we want a good health. How it will? It is not possible to, if you are not giving anything, either you should give time or you should give money to something, then only you will get the result out of it. If you are not giving anything, how you can expect yourself to be healthy otherwise? If you are not aware that something is wrong, something wrong is happening in your body, you will not go to a clinician, you will not search something how you can undo that or prevent that part. And what will happen? It will keep on progressing, and at one particular time you will end up with a particular significant disease which may take your life, right? So what is just to tell you that the most common the red color picturization in the diagram shows that is on the left side. It shows that usually where the heart attack angina progresses, but it might go on the right side in the similar fashion. It might go to the jaw, epigastrium, or even to the back or shoulders, right? So the basic aim of this awareness speech today is you should know what exactly is causing a damage to the blood vessel or the heart per se, which is causing some or other kind of the cardiovascular disease. It is alcohol and smoking. It is excessive use of the salt, excessive weight gain. It may be related to some surgery, secondary to some drugs. Your sedentary lifestyle, mostly you do the work from the home. Your poor dietary collection of your choices, what kind of food you eat. And of course, with the age, it may happen with hypertension. So these are the cuttings from the major Google searches. Why I put particularly this thing here is because most of the people, they don't go into the good text. They just search on the Google, and what they found is whether high blood sugar or high blood pressure is related with the heart problems, whether smoke is related to the heart problems, whether alcohol is related or any kind of tobacco abuse or high cholesterol is related to the heart problem. What you will find is, you will find yes, everything is having a very strong association with some kind of cardiovascular disease. It may cause blockage of the vessels, it may cause heart attack, it may cause stroke. Stroke means that blood circulation in the brain is hampered in some way, either there is a bleeding or there is clotting of the blood in some particular vessel, and that particular area get damaged. So what are those risk factors which are actually causing some kind of cardiovascular disease? We divide into two, uncontrollable and controllable. Controllable are those which you can control by your will, by your knowledge, by your education, by your awareness. And uncontrollable are those which are actually not into your control, and luckily these are only very few things: increasing age, ethnicity, your sex, and family history of heart disease. But what other controllable factors are which are major playing the role in getting some kind of cardiovascular disease are smoking, high blood pressure, high blood cholesterol, high blood sugar, obesity, overweight, obesity, and physical inactivity. So what is happening is, most of the people which I see in my clinics, in my wards, in my emergency areas, patients are taking blood sugar controlling tablets. They are taking tablets for their control of the blood pressure. But what they are doing is, they are taking the tablets today, and after 2-3 days or after a month, what they check randomly, they are checking their blood sugar or blood pressure is normal, under the control, and now they suddenly stop. They are happy. They are very happy that after 1 month of intake of the medicines, my blood sugar, my blood pressure is controlled, and now they are not checking it again. When they will check it, either they will get some kind of heart attack, or there is some kind of chronic headache, or they may get some kind of infection, severe kind of infection. They get it checked and they say, oh, at that particular time it was totally controlled, but now it came again. They are not aware about that part, that The medicine usually have a particular T-half. If you are taking it for some particular time, probably for 2-3 days, the blood pressure will be normal. But after that, if you stop taking the medication, there will be a reflex increase in the blood pressure, and that may cause bursting of the vessel in your brain. That may even cause the heart attack. The same happens for the blood sugar. That may happen that after taking some time, immediately after that, patient blood sugar was under control. But that person is not concerned about that part, that my blood sugar part is controlled because of the medication. That person is concerned that now it is controlled, now I should stop taking medication without consulting any of the physician or any other health expert. So the role of being a nurse, being a health expert myself, we have a role to aware the people that there are some risk factors which can be controlled. But if you are getting some kind of a particular disease like obesity, blood sugar, cholesterol, and blood pressure, high blood pressure, you should take medication for that. And you should not abruptly stop them. There might be change in the doses fluctuation. There might, if you attain a very good lifestyle, there might be some decrease in the blood sugar doses, medicine doses. If you are not able to afford your good lifestyle because of some constraint, it might be related to some work or family, then probably you may get more higher doses of the blood sugar controlling tablets. But that doesn't mean you will stop taking the medication when you find randomly you find a normal blood sugar value or normal blood pressure value, right? So while prescribing, even while attending any patient in the ward, while attending any patient, or not just attending, if you are talking with your friends or their relatives, do tell them, don't abruptly stop the medications. Now, the dietary recommendation for a healthier heart. If you see the two tables here, the right one and the left one we should take and right one we should avoid. But if you go with the list, even in each, there is potato skins, onion rings, dips, there is pasta, cheese, fried and cheese materials, donuts, biscuits, pies, ice creams, cakes, French fries, cheese. What you will see? You will notice that today everybody is eating only these things which are supposed to be avoided. If you want a good heart, if you don't want any kind of cardiovascular disease, but we are eating all of these and we are spending a lot of money. Even some people are going almost every day outside to eat these things. And then we say that we don't have money to spend on the preventive checkups. Then we say that we don't have time to go to the government hospital where the preventive checkups are almost free. And I would like to emphasize here, every government hospital have those preventive checkups which to be taken care of at a very early stage. If you are aware, you are not supposed to waste any kind of money. You are just supposed to go there and get it done. But since we are so much loose or so much unaware about our health and not responsible for our health, we are not taking care of our health first. We don't go to any clinician. We don't pay attention to that part. If you are having even a chest pain or some kind of other problem, we just ignore that part till that comes to that much pain that it is hampering your lifestyle. We try to avoid that. And since we avoid, we don't have tendency to go to the preventive checkups. That's why we end up in a stage where we get more tests done, and that's why we feel that now the burden of healthcare is increasing. The lack is from our part that we are not aware. We should go earlier, because I told you that example was just to tell you that part up to 60% of the block is the coronaries. You get multiple alarming signs in your body and at multiple point of time where you should have been alert. You should have go to the hospital or any clinician and get the test done to get what problems you are having at that particular time and what you can do to prevent yourself. But most of the people, up to the 80 to 90% of the people, reach when there is almost a complete obstruction and patient have a frank MI, right? So American Heart Association, European Heart Association, the major bodies have given us 7 steps ladder to a healthier heart. And what that this particular 7 steps ladder is saying is, you should you should eat healthy, you should get active lifestyle, you should control your blood sugar, you should control your blood cholesterol, you should target your you should not smoke, you should maintain your body weight, you should control your blood pressure and sugar part. So these are the 7 steps which are actually leading you to a particular state where you are getting a good lifestyle, a good heart, or your heart, and you are not getting any other of the cardiovascular disease. Now, here I particularly would like to emphasize on how you should do the second ladder to get active. The recommendation is only 150 minutes per week. Often aerobic exercises which increase your endurance, stamina, and actually utilizes the fat, body fat, burn that fat, and decreases the cholesterol level, decreases the glucose level inside your body. But what is happening is, just for an example, the females of our usually the females in India are doing the household work. Less of the males are doing that. So just giving that example for that sake, no particular other intention I am having at this particular point of time. The most of the females who are doing the household work, just tell me, don't you think that they are doing much work than any other male who is actually going outside, sitting in an office from say 12 hours in a day, or say 18 hours in a day? But the female who is running all around the house, sometimes going upstairs, coming down, taking lifting few weights and putting here and there, cooking food multiple times in a day. That female is actually doing a lot of activity, but that doesn't count here. If that would have been counted here, the female should have a good heart, should not have any cardiovascular disease, should not be obese, should not have sugar, uncontrolled sugar level, should not have uncontrolled blood pressure levels. And that is not the scenario. The females, very much a good percentage of the female number is having increased blood cholesterol, increased body weight, blood sugar, uncontrolled blood pressure, and they are having heart attacks and other cardiovascular disease. Why this? Because there is a particular way of achieving this 150 minutes in a week. And the best result will be if you are doing it almost 30 minutes in a day. And what is that? You can break up that 30 minutes into 15 minutes in the morning, the 15 minutes in the night. But what is the main aim of those 15 minutes particular is you should take the minimum rest between those 15 minutes. It should not be like you are walking for an hour, but you are talking with other people. You are not even having a single drop of sweat. It should not be like that. It should be gradual. Your stamina should be increased gradually, but it should be in a way that in the 15 minutes you are taking only for 30 seconds or 1 minute maximum rest. And rest of the 40 minutes you are walking. And you are walking at a particular pace that your heart rate reaches to the touching almost to the maximum upper limit which is possible for your body. And what is that? Roughly we said that 220 minus your age particularly is roughly the upper limit of the heart rate which your heart can achieve in a safer way. Although some conditions are applied, you should consult your clinician first before pushing yourself to that limit. But yes, up to that point you can do. And when your heart rate goes to a particular level, then only your body fat start burning. Then your body insulin start rising. Then your blood sugar part start controlling. Then your cholesterol part start going down. Then your blood vessels start reacting in a way that your blood pressure part start getting controlled. So there is a way of doing exercise. You have to walk, but you have to walk in a particular way, in a particular speed for a particular time, so that you get the results, better results. Otherwise, 150 minutes walk in a week, I am sure everybody who is present on this planet is doing it. But we are getting heart attacks. We are getting heart attacks because we are not doing it in a proper way, right? So just telling you here what are the ideal weights for the man and the woman as per the height. Mostly we we are today, in today's scenario, what I'm seeing is most of the younger people, younger females particularly, they are getting obese. And obesity is leading to another kind of problems in particular females, that they are getting infertile in the longer period of time. They are getting more of the heart attacks, and they are even getting more of the cosmetic problems. And most of the female, what I have seen is they are relating to that part is that they are having PCOD or PCOS, and that is causing the obesity. They are not concerned about controlling themselves. Might be true that it is difficult to control that blood weight, body weight, but you can do that part if you are following a particular lifestyle. And how that is, you are supposed to eat good, you are supposed to work out good, and if needed, you are supposed to take medicines on the right time and get a follow-up. Only the 4 steps you are supposed to follow, and the result will be dramatically in a gooder way. Right? And the males too. The males are also younger people, especially even the school-going children, they are getting too much overweight, and this is not actually right or good in this scenario, that if you are getting overweight in your younger age group. This may lead to very significant problems related to your cardiovascular health in your adolescence or young youth, when you will be more than 35 years of age. How smoke is affecting you? It increases the total triglyceride levels and LDL, which is the bad part of the cholesterol, which is actually damaging the blood vessels, making the clots there. It decreases the HDL, which is the good part of the cholesterol, which actually prevent your heart from going into a state of heart attack. It causes the nicotine, causes the platelets to aggregate, increases arterial spasm. It increases the oxygen requirement of cardiac muscles, constricts the blood vessels, and it causes irregular heartbeat. Now, this particular slide I kept here just to let you know that today we are doing lots of smoking, lots of other substances in the form of amphetamines, even cocaine and hashish, marijuana, and weed. We are also drinking a lot, and this particular time you should be aware what is right for you. Here on this slide, the recommendation is being made because the people are not stopping drinking. But let me tell you, even the single drop of alcohol, if it is going inside your body, it will cause damage. Yes, these are the recommendations just to decrease the likely damage secondary to the alcohol part. Earlier, we used to say that wine is cardioprotective, but it is not. It will cause damage to your heart. It will cause cardiovascular disease. So even the single drop of the alcohol is damaging. But if at all you want to drink, then for the female, 1 drink in a day, and the for males, maximum 2 drinks in a day. 1 drink we usually call the 30 to 40 ml of drink. And you are taking, if it is more than this one, then it will definitely cause you damage in more negative way. So the aerobic exercises, which increase the endurance level, are good for your heart and the other brain, even for increasing your memory. And what other aerobic exercises are? These are the running, hopping, jumping, and even the mountain climbing. These are the exercises which you can do to rowing, which you can do to keep your heart healthy. I bring this point because this particular webinar is going to the college which is based in the Bangalore, the southern part of the India. What we do there is in India, particularly all of the northern India and the south India both, we use mustard oil for the cooking. And in the southern India, we use coconut oil for the cooking. Right? So here's the fact that the mustard oil is full of the omega-3 and the omega-6 fatty acids and the monosaturated fatty acids, which are actually good for your heart. And so it has been seen that the mustard oil is actually good in preventing the heart disease in the longer run. While the coconut oil, which also has monounsaturated fatty acid, but it has that monounsaturated fatty acid in a lower fraction. It has more of the saturated fat, and it increases the LDL level in the longer run. And the more the LDL level, the more the chances of atherosclerosis, more the chances of heart attack and other cardiovascular heart disease. So it is not good for the heart, particularly if you are taking it for a longer period of time. Although it is good for other diseases like pancreatitis, Alzheimer's, even for your hair, your skin, but it's not good particularly for your heart. So if you're choosing it for as an edible oil in your food on daily basis, you have some member in your family who is having some kind of cardiovascular disease, you should think twice before using it again. You can go for the mustard oil, but even the southern world is actually promoting olive oil, and that is also a good choice to have an in oil for to cook the food. But the mustard oil, particularly which has been used in India in the more refined form, is more good and of more use if you are using it for cooking the food methods. So I'm opening you all for if you have any particular question related to this part. Hello. Hello.
Yes.
Any particular question, if you are having particular to this topic, you can ask right now.
Either in chat or you can straight away ask. Anybody?
Dr. Ankur, I have a question for you.
Yes, please.
Dr. Ankur, so would it be good to combine mustard oil and coconut oil and then maybe alternate and then you have it?
No, the particular point which I particularly mentioned here is the coconut oil is full of saturated fats and lesser fraction of the monounsaturated fatty acids. The monounsaturated fatty acids and omega-3 and omega-6 fatty acids are good for your heart. Saturated fats are not good for your heart. So if you are combining it, you are actually, the fraction of your oil which is being used in the food will be having more of the saturated fats compared to the monosaturated fatty acids. So they will be damaged to your heart. So if you are having a particular person who is having some kind of hypertension, diabetes or obesity or any kind of cardiovascular heart disease, you should avoid.
Okay. Thank you. So in South India, especially they use coconut oil most of the time.
Particularly
they do not. Would you suggest any specific oil for them?
You can shift to mustard. You can shift to olive.
Okay. Perfect. Thank you.
I particularly point
so
out
much.
this point. I particularly point out this point only for this purpose because that's a webinar is based for a university which is in the Bangalore, in the southern part of the India, and I am aware about
absolutely.
that part, that people are using coconut as the edible oil there.
Yeah. Thank you, Dr. Ankur. That was
again,
insightful.
thank you so much for inviting me here. Thank you so much. Thank you so much.
Thank you so much, Dr. Ankur. It was great. Thank you.
Thank you, sir.
Thank you very much, sir.
Hello, Dr. Ankur, sir.
Yeah.
Hello.
Hello.
So, Dr. Ankur, sir.
Yes.
I have one question. So,
Yes.
what are the biochemical investigations they're doing from the cardiac profile, sir?
What are the biochemical
investigation from
you should go for the cardiac and cardiovascular disease, right? The first of all you should go for the ECG.
Yes. Okay.
A single investigation which you need at any particular time is ECG. If ECG is troubling, like I said, their cardiovascular disease are in the form of, it is related to blood vessels, it is related to the heart or the brain. Right. For the heart, you should go for the ECG. For the brain, you should go for the CT. And for the peripheral vessel, if you are having some kind of particular, you should go for the Doppler.
Okay. Sir, what about from troponin I, sir?
Troponin I will go for the next level if your ECG part is being showing some kind of the damage in the form of some kind of ischemia. Then the biochemical step, biochemical investigation which you will choose is troponin I and troponin T. Troponin I is preferred over the troponin T.
Okay. So based on to the troponin I, it will be in normal or abnormal, it's okay fine. If there is abnormal, it will get it from a troponin I. So what we have to do the medical, like a medicine we have to take.
If you are having changes in the ECG, if you are having troponin I positive, that means you are having an heart attack. That means you are
Okay.
supposed to go under the evaluation part. Whether if you are reached at a particular time, we have a window period when you are having the symptoms and you are presenting to us. If you are within that window period, we will go for the angiography and stenting at particular immediately. If you are out of that window period, then we will go for the oral medication first. We control the other risk factors and then we electively go for the angiography and stenting.
Okay, sir. One more doubt, sir. If the pregnancy time, their cholesterol level is high. So what to do? What is the suggestion they will give, sir? Sometimes I saw that so many patients like they have more than the 300 cholesterol to be there in pregnancy time. Any like cardiac arrest history, it will be possible or not, sir? Like that.
Only the total cholesterol part is 300, or you are having raised LDL and triglyceride also.
Yeah, LDL it is on nearest in the borderline, but cholesterol is high.
You can give some dietary modification to that particular child without any modification, without any addition of medication at that particular time. And you can, as I told you, what is the right way of doing the aerobic exercises, you can suggest that particular thing to that person.
Because some of the patients they're coming with my clinic. The patient they're suffering from the cholesterol levels high. They're more than 350. But
How old is the child?
So child is on the pregnancy lady. The pregnancy lady is on cholesterol level is on more than 300, and they have the 6 months baby, like
and
including from the.
And she is not having any blood pressure or diabetes.
No, sir. There is no random blood sugar in it.
Is she obese?
Yes, sir.
Yes, secondary to obesity is that part, and you are not supposed to do anything at that particular point of time. You can leave it that way if that real part is normal.
Okay. Thank you, sir.
Any other thing? Should I leave?
I think that's no more questions. Anybody else? So
thank you so much, sir. Thank you so much, sir.
Thank you very much.
Thank you so much, the whole nursing department. Thank you so much.
Okay.
Thank you, sir.
So we can have the second speaker now.
Wow, that was a really thought-provoking and interesting session. We are able to understand about the various perspectives of cardiovascular health.
Yes, ma'am.
Okay. So,
hello.
Mr. Deshant is there already now? Yes.
Yes, sir.
Okay. So it was a nice presentation, a comprehensive one by Dr. Ankur, and now the turn is for Mr. Deshant.
Yes, sir.
Who is Mr. Deshant himself is pushing the slides? Or,
yes, sir. I'm
okay.
sharing my screen, ma'am.
Okay. So to introduce Mr. Deshant, SC College is doing it, or
can you please enable my screen share? Hello. Can you please enable the screen share? Yes.
You can introduce him also, Mr. Deshant.
Yes, sir. I'll do.
No. Let they will be giving the introduction. No. Hello. Okay, in that case, I will speak up. for Deshant. Deshant is already working with the Vardhaman Mahavira Medical College and Safdarjung Hospital as the nursing officer, and he is a trauma nurse coordinator also. And in addition, if you just Google about him, you can just see his videos and how he is intervening for the cardiac arrest people and all with the motorcycle team of the Delhi government and all. So that is also there, that is I have seen. And in addition, I'm really proud that he is there in our team as well. That anytime and every time he is there with a smile to serve the patient. And as always say, if you find somebody without a smile, you give yours. As a true professional nursing officer, he's doing that. So that's really a great thing. So we shall just give the floor to Mr. Deshant.
Yeah, sir, let me interrupt. I will
Yes.
just give a few a note on Mr. C. Deshant, trauma nurse coordinator.
Yes, I was waiting for that. Yes.
Yes, okay. Fine. So we have with us our next speaker, Mr. C. Deshant, trauma nurse coordinator, Safdarjung Hospital, New Delhi. So to introduce about Sir completed his UG nursing graduation and postgraduate diploma in disaster management, post-basic diploma in critical care nursing, along with BLS and ACLS certification from American Hospital Association. Currently, Sir is a registered nursing officer and trauma nurse coordinator in emergency department of Safdarjung Hospital. Let me give a few career highlights to mention about Mr. Deshant. He worked as an emergency nurse in Narayana Hrudyalaya, Bangalore for a couple of years. Sir also worked as a motorcycle responder in Mission Delhi project towards pre-hospital thrombolysis of heart attack and cardiac arrest in patients at All India Institute of Medical Sciences, Delhi. We are happy to have you with us in this conference, sir. I request sir to share his valuable thoughts to our delegates and enrich us with your knowledge. Over to you, sir.
Thank you, ma'am. Thank you for that warm welcome. Thank you, Hamza sir, for this opportunity as well. And Suresh sir also for giving this opportunity to share my experience as a professional nurse in maintaining cardiovascular health of patients. And for the chief guest, very good morning, Dr. M.K. Ramesh, the Honorable Vice Chancellor of Rajiv Gandhi University of Health Sciences, and Professor and Dr. Bimla Kapoor ma'am, who is the chairperson of National Nursing and Midwifery Commission 2020, and a nursing expert and a mentor of nursing fraternity actually, and other dignitaries of the palliative pain and palliative management. Thank you, Professor Sneha Balgoi ma'am, for this opportunity, for giving this a small couple of few minutes to share my experience as a nurse in the emergency department. To focus with, as today is the World Heart Day, as we celebrate it, why there is focus on cardiovascular health. The data which has been collected from the World Health Organization, in India, the cardiovascular diseases is the leading cause of mortality in India. Out of which, the ischemic heart disease, which includes acute coronary syndrome and stroke, are the predominant ones. These contribute around greater than 80% of the cardiovascular deaths in India. Compared to the global data, which is 235 deaths per million population, India is greater than, it is on an upper hand, where it is very disheartening that Indian population do not have the management of cardiovascular health, where we can see the number is 272. And why is it important to focus? Because if we compare the year, 2 decades earlier, like 1980s and 1990s, the predominant epidemiological transition, previously 20 to 25 years back, the predominantly epidemiology was infectious diseases like flu, typhoid, cholera, leprosy, and undernutrition like marasmus, protein allergy, malnutrition diseases in the childhood, and maternal and childhood diseases like measles, mumps, chicken pox. Those were the predominant diseases which were existing at that time. And after 2 decades, that is very brief amount of time, where the non-communicable diseases like ischemic heart disease, stroke, hypertension, diabetes mellitus, cancer, etc. have taken over. And during the same time, the disease burden of the infectious diseases and maternal disorders have decreased to 50%. And the life expectancy of the at birth has increased from 58.3 to 65.2, thereby increasing the aging of population too. And Professor Bimla Kapoor ma'am has also already emphasized that the immature deaths below 70 years is on the higher side, which is contributing to the cardiovascular diseases. And compared to the global data, India, in all the parts of the India, like rural areas and poorer states, CVD emerges as a leading cause of death. And coming to the assessment of patients who are having cardiovascular diseases, as soon as a patient arrives, nurses have a very significant role, both in pre-hospital and in the hospital setups. In the pre-hospital, like working in public health or community health nurse, it is very important to identify patients, or if you witness a patient having a cardiovascular disease symptom, it is very important to direct them as per the standard protocols. Like if you cannot just advise them to take the patient to a smaller clinic, it should have a stroke clinic or cardiac unit where the immediate primary PCI or thrombolysis can be done. This is very important because many patients in tertiary hospitals come from many hospitals, referred from 2 to 3 hospitals where they do nothing except referrals. We receive patients without even giving basic medications for heart attack. In Kerala, the experts say that age about 35 and plus should carry loading dose of ACS, that is myocardial infarction, like clopidogrel, aspirin, and atorvastatin. This is very important. Like people carry credit cards in the purse, the loading dose of this drugs is very timely useful when the patient experiences that sort of pain. And in the assessment in the hospital, as soon as the patient arrives in the emergency or in the ward, if the patient experiences such kind of symptoms, it is important to evaluate the vital signs and the level of consciousness of the patient at that time. If the vital signs and the level of consciousness isn't at optimum levels, then stabilization of that is very important. If the patient is hemodynamically stable, then the patient can be done for a thorough physical assessment. The patient can experience symptoms like most of the typical symptoms of cardiovascular diseases will have chest pain, dyspnea, dizziness or syncope, palpitations and cyanosis of face, hands, lips, and edema in the legs, hands, and unusual fatigue. And how to approach the patient with chest pain. If you see patients coming with symptoms of chest pain, you should initially assess the patient's origin of chest pain. Is it coronary or extra cardiopulmonary disease? That depends on the further characteristics of chest pain, where few patients with chronic diabetic mellitus, they do not experience chest pain. That will have ECG changes and other symptoms like dyspnea and palpitations, and they will experience a silent ischemia, which is also prevalent in aged population. And to see the chest pain characteristics, we should follow these criteria when the onset has taken place and how much duration it has taken place. Because in chest pain and acute coronary syndrome, the time is muscle. Because as the time, every minute counts, and as the time goes off, the cardiac muscle gets damaged. And the site of pain where the chest pain actually has, and the character of pain, and what is the aggravating factors that contribute to this pain. And some patients have relieving factors. When they sit in comfort position, they get relieved. And the associated symptoms like dyspnea, diaphoresis, like profuse sweating, palpitations, these all will be visible. Onset, it can be any sudden onset, and it could be considered as a vascular problem. It could be a coronary blockage or a pneumothorax. Pneumothorax is usually in patients with cardiopulmonary diseases. And if you see the pain, the onset and duration of pain, the site of pain, retrosternal pain with radiation to the arms, jaw and neck. This can alert us that it could be a myocardial infarction or an acute heart attack. And chest pain along the trapezius ridge, that can indicate they might have a pericarditis, and they will have a history of fever and other symptomatic issues. And the pain is radiating towards the back. It could be acute aortic syndrome. And if you come to the characteristics, if the pain is tearing or ripping pain, it could be acute aortic dissection. It could be related to trauma and accident cases. And if there is burning pain, it could be due to indigestion or dyspeptic pain. And there is squeezing discomfort, then it could be esophageal spasm. Even in this esophageal spasm, there will be patients having radiation of pain towards the arms and jaw. Then you should distinguish between both acute chest pain of ACS and esophageal spasm. And the next is sharp shooting pain, where it could be a pleuritic pain, where the patient might be experiencing a pleural effusion. COPD cases, they will have a pleuritic pain. And aggravating factors. When there is, the chest pain might increase due to physical stress and some factors like smoking or exposure to cold. Like in Delhi and northern cities, the winters are so extreme that in the winter season, the cases of acute MI are more. If the pain increases with inspiration, it could be a pleuritic pain because lungs are involved in it. And if there is change in the intensity with position, then it could be a musculoskeletal pain. There could be athletes playing and running and doing everything, they will have chest pain. But when you conclude, when you ask the patient about the history, how the pain aggravates, then they used to say that when I sit this side or when I lay down on the left or right side, the pain increases. That could be a musculoskeletal pain. And relieving factors. In cases of acute coronary syndrome, a sublingual nitrate will relieve pain in minutes. That could be of angina. And if the posture pericarditis is intense in supine position. And associated symptoms of cardiovascular diseases are like nausea, vomitings, and which are related to inferior wall MI. And symptoms of MI include diaphoresis, that is profuse sweating, dyspnea and fatigue. And patient might explain there are brief syncopes in their history. That could be a postural hypertension when they suddenly wake up and they have syncope. And it could be arrhythmias, which could be further investigated by doing an ECG or connecting the patient to a cardiac monitor. And if the patient is in syncope and there could be a history of convulsions or seizures also. And patient comes in unconsciousness, and patient might be a patient of diabetes mellitus. The patient could be of hypoglycemia too. And before going to the cardiac history, we should stabilize the patient accordingly. Hemodynamically, the patient should be stable, and we should get the cardiac history from the patients if the patient is not able to cooperate with it. And these are the cardiac history which needs to be obtained, because it is vitally important that what all the past health history he had and medications he is on. Like many palpitations are due to the medications he is on, and the allergies he is on. Many patients are allergic to aspirin and antiplatelet drugs. And social and personal history, like the lifestyle they are following, the smoking, tobacco consumption, alcohol influence, all these contribute to the cardiovascular diseases. And when you inspect the patients with cardiovascular diseases, if they have cyanosis or pallor in face or lips or fingertips, then it could be pure perfusion or decreased oxygen levels in the periphery of the patients. And jugular vein distension. In patients with right ventricular failure, in normal patients, there would be no distension of jugular vein. But in patients with right ventricular failure, if the patient is laid down and the head of the bed is at 30 to 40 degrees level, there will be elevated or distended jugular veins. Here you can suspect the patient might have a right ventricular failure or tricuspid regurgitation or constrictive pericarditis. And you can see the patients with edema, and where the patient's peripheral edema is caused by infection like pericarditis, endocarditis, congestive heart failure, thrombosis, venous insufficiency, and accumulation of fluid in the intracellular spaces. And patients mostly having the cardiovascular diseases will indicate finger clubbing. As you can see in the picture, there is finger clubbing where the angle of nail is above the nail bed. It indicates central cyanosis. And the second thing to identify the capillary refill time, CRT. The normal, when you put a pressure on the nail bed and create a blanching for 5 seconds, and when you remove the pressure, if the perfusion or the redness comes back in 2 to 3 seconds, it is 1 to 2 seconds, it is adequate perfusion. If it is more than 2 seconds, there is poor peripheral perfusion. And then we go to the palpation technique, where when you palpate the patient in normal scenario, the patient will be symmetrically warm. And that suggests adequate perfusion in all over the body parts. If the patient is cool and sweaty, and patients with ACS, they will have profuse sweating. In that cases, the patient's skin is cold and calming, where you can identify the patient and send the patient to the critical red zone or the cardiac emergency wherever as possible. And in cases of irregular pulses, when you palpate for the pulses, if you have an irregular rhythm, then you have to check. As nurses, we used to check 15 seconds and we used to multiply by 4. If it is irregular, then you have to go for a full 60-second measurement. If you feel there is bradycardia or tachycardia, it could be an atrial fibrillation also. It is at most priority to send the patient to the cardiac emergency for immediate resuscitation. And check for carotids. If the patient has previous coronary history and CAD history, the patient will have bruits when you palpate the carotids. And on auscultation, apart from the normal heart sounds S1 and S2, you can hear murmurs that is due to tricuspid or mitral valve regurgitation. And when you auscultate the lungs, you can see crackles in cases of pulmonary edema. And in cases of pleural effusion and stony dullness, there is absent air entry in one or the other side. And as you see, the patients coming with ACS will definitely have a hypertension, and blood pressure is a major contributing factor for cardiovascular diseases in our country. And we usually interpret hypertension as the systolic BP is greater than 140 mm of HT, and the diastolic BP is greater than 90 mm of HG. And coming to the list of cardiovascular diseases we have, these are the main cardiovascular diseases. That is coronary artery disease, that is ischemic heart disease, the most common type, where the coronary arteries gets narrowed or blocked, and there is decreased blood supply to the heart muscle, that is myocardium. And the second one is heart attack, myocardial infarction, which is usually a blood clot. It could be a lipid or atherosclerotic clot or lipid blockage that cuts off the coronary supply to the myocardium, where this is utmost priority that the patient is attended and urgent medical attention is received. Otherwise, the patient might end up in cardiac arrest. And the stroke, the third one, stroke or CV, a cerebrovascular accident. If the clot is dislodged to the brain and it blocks a temporary disruption into the supply of oxygen and blood to the brain parts, then it could cause stroke or temporary paralysis or permanent if not attended by the medical experts. Out of these, the ischemic heart disease and stroke together contribute about more than 80% of the cardiovascular disease burden in India. The other cardiovascular diseases in India are arrhythmias, where you find irregular or abnormal heartbeats, and aortic diseases. There's a chronic cases, and in trauma cases, you usually find aortic dissection or trauma. And cardiomyopathies, secondary to some other primary issues or diseases, cardiovascular diseases, congenital heart disease, where the child itself have diseases at the time of the birth, and deep vein thrombosis and pulmonary embolism, where you find blood clots in the leg veins, which can dislodge to the heart as well to the brain, where it can create ischemic heart disease or stroke or cerebrovascular accident. And heart failure, when the heart isn't pumping good enough to supply blood to the whole body, then it could appropriately be a heart failure. And heart valve diseases, the heart valves like tricuspid valve and mitral valves do not function in a proper way. Rheumatic heart disease, where the damage to the heart muscle and heart valves from the rheumatic fever caused by streptococcal bacteria. And peripheral vascular disease, this include diseases of the blood vessels supplying to the arms and legs. And we have already discussed, and Dr. Ankur has already emphasized on the typical symptoms of cardiovascular diseases. Those are chest pain, chest tightness, chest pressure, and chest discomfort. There would be pain, weakness, and numbness in legs and arms, shortness of breath, easily tiring, unusual fatigue, very fast tachycardia or bradycardia, palpitations, where the patient experiences his own heartbeat, and dizziness or lightheadedness that can end to syncope, and swelling of hands, that is edema, and skin rashes or unusual spots. Coming to the risk factors of cardiovascular diseases, we can see the WHO organization has given a few risk factors which contribute a major part of the cardiovascular diseases like high blood pressure, high cholesterol, obesity, air pollution that is very appropriate to the cities, metropolitan cities like Delhi and Bangalore, and decreased physical activity in population of India, and unhealthy diet like junk foods and diabetes, consumption of tobacco, kidney diseases, and harmful use of alcohol. And coming to the statistical data of tobacco in India, more than 1/3 of adults in India use, that is 35% of the population use tobacco. That is a very alarming rate. And smokeless tobacco, and that is chewing tobacco and smoking of BD, are the most common of these 1/3 of the adults who are into this tobacco consumption. And smoking prevalence among the genders, like in men, it is around 24%, and in women, it is 3%. It is very alarming that tobacco use is increasing rapidly among young adults as like 20 to 35 years. And as the education gets lower, the increasing rate is also higher. And in metropolitan cities, it has become a fashion taboo. Smoking has become a fashion taboo. Like the colleague is smoking and he will automatically influence the other person with him. And moreover, the passive smoking is more higher in India. And lack of unhealthy food or decreased consumption of fruits and vegetables. These are the statistical data which are found. In perception, like Indians used to predominantly consume more of fruits and vegetables, but when the data is collected, the rate of consumption of fruit and vegetables is very low in India. As per the National Family Health Survey 3, half of the population in its survey consumed only 1 or 0 of fruit in a week. That means it is also explained because the cost of the fruits and vegetables are on higher side. The vegetables that are consumed are also often overcooked. In Indian meals, the vegetables are overcooked, which leads to the vital loss of micronutrients, which are essential for the healthy heart. And WHO recommends there should be more than 5 fruits. It could be any seasonal fruits and vegetables daily. And this recommended consumption is only seen in 1% of the population in India. That could be people who have health advisors, dietitians, and everyone. And high cholesterol, the third risk factor. The National Sample Survey Organization surveys indicate that Indians' fat intake is increased from 24 to 36 gram, and from 36 to 50 gram in rural and urban individuals respectively, without change in the total calorie absorption. That is, if an average person is taking 500 calories of diet, out of which the fat intake has increased rapidly over the years. And partially hydrogenated vegetable oils with high trans fat content is also more in the significant proportion. Most of the packed vegetable oils, packed foods, tinned foods, all have hydrogenated vegetable oils for preservation, and which contribute to the bad health of the population. The consumption of partially hydrogenated vegetable oil is particularly common in urban slum dwellers belonging to the lowest socioeconomic status. That is also very important because poverty has taken a major area of Indian population. So the socioeconomic status plays an important role in the health and the diet habits of the Indian population. And coming to the physical inactivity, that is, as Dr. Ankur has emphasized, Indian physical inactivity has decreased very slow, has come very low. As per the ICMR studies, every individual in the study was considered physically one of the means out of two, one individual is considered as physically inactive, means he doesn't do any activity of that sort to expenditure his energy. And physical inactivity was higher in urban areas because the patient, in urban areas, most of them are employed in a sedentary lifestyle, and individuals of higher socioeconomic status are into the physical inactivity. And smart gadgets, which has reduced our physical activity in the recent years, which reduced our physical activity, like population, people used to go to the electricity boards and other centers to pay the bills, but now it is everything happen in the smart, like a click away, you can do everything in the smartphone, which has further reduced the physical activity. And the fourth is the hypertension. In adults, Indian adults, it is estimated that 30% of hypertension is available in the Indian population. And in India, average blood pressure has increased in the past 2 decades, whereas in most Western countries, it has declined. Like, it could be due to stress, it could be due to cardiovascular diseases, and this 30% prevalence of hypertension in adult Indians is very alarming rate, which can further deteriorate the cardiovascular health of the population. The number of individuals with hypertension is expected to be double from 118 million in 2000 to 213 million by 2025. This is WHO's estimates, where the hypertension cases may go up or double in the next coming couple of years. There is also a study that shows low educational status is associated with lower rates of awareness, treatment, and control of hypertension. And the further one, the diabetes, which is in India, it is considered as the diabetic capital. The prevalence of diabetes mellitus has almost doubled in the past years. That is from 9% to 17% in urban, and in rural areas, it has quadrupled from 2% to 9%. And it is also estimated that the number of individuals with diabetes mellitus will increase to 101 million by 2030. And what are the social determinants of CVD? All the above risk factors and the data which has been collected, I have been emphasizing on this because it is very alarming that a major percent of cardiovascular diseases are prevalent in Indian population. And what are the social determinants of cardiovascular diseases that are happened in the Indian population? Because most of the diseases, cardiovascular diseases, are underdiagnosed. The population of the lower social economic status go to the smaller clinic. They ask for they tell the chief complaints, and they ask the doctor for a medicine. As soon as they receive that medicine, and they get relieved, and they stop the medicine. And these cases are not reported even. And these are underdiagnosed and underreported. There is no follow-up in the tertiary centers. These patients come afterwards with a different and elevated problem of cardiovascular disease. And most of the patients are coming from the economically underprivileged or lower socioeconomic status groups. For example, the 30-day mortality rate attributable to ACS was 8.2 for the poor in comparison to 5.5% for the rich. Means as soon as the patient comes to the hospital, if you take the mortality rate for 30 days, the rich has a chances of 5.5%, and the mortality rate of the poor has gone to 8.2. And the burden of high out-of-pocket payments and financial distress. In India, there is no adequate socio-economic activity, and the out-of-the-pocket payments, like in government institute, it is overburdened and workload, too much of workload. And when the patients go to the private institutions, the payments are too expensive, as Dr. Bimla Kapoor ma'am has emphasized. Example, the lower income group in urban India spends 34% of its annual family income for diabetes care, where means 1/3 of his income is totally spent on the health expenditure. And he is further pushed back to the poverty of the vicious cycle. And how do you prevent CVD, cardiovascular diseases? This has been already emphasized by Dr. Ankur, where it starts from control of the healthy diet, decreased salt intake, and quitting the smoking, and pollution-free environment, managing blood pressure. As soon as you found out that the patient is having hypertension, he should be regularly followed up in the hospital for controlling blood pressure. And the same way, the diabetes is also should be identified at the earlier stage and managed to prevent further cardiovascular damage. And the patient should be physically active to prevent the cardiovascular diseases. And to see that diabetes, the obesity is under control, healthy body mass index should be maintained. And sleep is very important part of prevention of cardiovascular diseases, because a minimum of 6 to 8 hours of sleep is very essential to relieve from stress and unnecessary pressure to the cardiac muscle. And avoiding junk food, the importance of oil. Sir, Dr. Ankur has already emphasized on the importance of oil, like mustard oil, coconut oil. Many experts say that randomized use of oil, different oils, because every oil, edible oils have different vitamins and saturated hydrocarbons, which is essential for human body. And know your numbers. Like cholesterol, you should know the base data of your own self, that your LDL levels, HDL levels, triglycerides, your body weight, blood pressure, and the sugar levels should be known, so that a basic data, baseline data is being generated to compare yourself when you are into a problem. And most of the people consume packed foods from supermarkets and everyone. Every food packet will have a nutritional label on the backside. You should check food label for the trans fat amount, percentage, so that you can control the amount of fat intake, and the cutting off sugary beverages like alcohol beverages like Coke, Pepsi. All these have high amount of sugar levels, which increase the diabetes prevalence in our population. And take the stairs, which is very important, because to increase the physical activity, such like in metropolitan cities, high-rise buildings, when you go down to the ground floor, it is better to take stairs so that you increase the physical activity. And for sedentary lifestyle, it is important to you take a break from long periods of sitting. And it after 25 to 30 years of age, it is very important to find out that you have diabetes or not. And family history also matters, because many of the coronary cardiovascular diseases are hereditary process, and it is very important and plays a role in the further generation. And social prevention. Coming to the social prevention, we should generate, as nurses, especially community health nurse, we should generate social awareness and spread of knowledge about cardiovascular diseases and its health. And cardiac rehabilitation. Most of the patients who have hypertension, diabetes, they do not adhere to the medication. As Dr. Ankur said, they usually take medicine until they achieve a control of that BP, blood pressure, or diabetes. As soon as they achieve it, they think it has been controlled, and they abruptly stop the medication, thinking that they no longer need it. But that worsens the condition of the patient. And towards the Indian citizens, Indian settings, we need to encourage innovative methods for the social prevention of cardiovascular diseases. Like for basic life support, in Western countries, if the patient collapses in on a roadside or somewhere in the hospital or in the airport or railway station, there is availability of AEDs everywhere. But in Indian settings, the AEDs are inadequate, and it is very costly to supply a large population like 130 crores. So it is very important that hands-on CPR, like calls compression only life support, is very essential at that time. So awareness of basic life support is very important to everyone. And coming to the role of cardiac nurse in managing a patient with cardiovascular disease, it is in the hospital, it is very important that triaging is made proper, because triaging is very essential in a hospital where the patient goes further for the resuscitation or the management. Every minute counts in cardiovascular diseases like acute coronary syndrome, where golden hour is being missed. And in the hospital setups, it is important that patient admitted in ICUs or wards, the nurse's responsibility is to recognize the patient early and manage the patient in the pre-arrest condition itself, so that you prevent the patient ending up into a cardiac arrest. And the nurse working in an ICU and emergency should have the knowledge regarding the popular and prevalent cardiovascular diseases and their treatment protocols that are followed as per the institutional policy. And all the emergency and ACLS ICU nursing professionals should be skilled in advanced cardiac life support, where they can follow the protocols as per the policy and revive the patient at the right time. And it is very important that Dr. Bimla Kapoor ma'am has also emphasized, we should assure the patient that the patient is in the safe hands of the hospital. And through empathy and compassion, the patient, it is nurse's responsibility to counsel the patient that he will be okay and reduce the anxiety of the patient to further improve or elevate the suffering of the patient. And nurses should be familiar with prompt IV administration. Like in cases of cardiac arrest, patients are given life-saving drugs, and most of the drugs are given in an improper way. Like in cases of drugs like adenosine, they are given rapid IV push along with a 20 ml NS flush, which is not followed in many of the hospitals. And every drug which is followed in advanced cardiac life support needs very important and which is required for the patient's survival. And timely medications. Doctors prescribe medications as per the patient's requirement, but it is our nurse's responsibility and to give the medications to the patients on time-to-time basis. And you should see the patient has taken the previous medicine or not. And based on the continuous monitoring of the patient, the medicine should be altered with advice of the expert opinion. And in cases of acute coronary syndrome, there is pre-thrombolysis checklist in most of the hospital emergencies where these things are followed before a thrombolytic drug like clot buster drug is being given to the patient. And the nursing professionals should also have the knowledge of use of equipment in the cardiac department or ICUs, how to use a defibrillator, ventilator, ECG machine, how to take an ECG, how to connect an NIV, non-invasive ventilation machines, infusion pumps and pacer machines. In case most of the nursing professionals, because every equipment varies from different brands. So the options in the devices vary from brand to brand. So it is important that every nursing professional is have knowledge about the devices they use in the department or the ICU, so that they can use in the right way at the right time. And nursing professionals should also have the basic knowledge of ECG reading, because even the layman, when he gets an ECG, he used to see the patient ECG as if he knows everything. But as nursing professionals, we should know the basic rhythm changes, like in acute coronary syndrome, ischemic changes in the ECG, like ST elevation, ST depression, T wave inversions, and Q waves in cases of necrosis, past history of MI. These cases should be immediately informed to the physician so that apt treatment is being provided. Because in Western countries, if the patient doesn't follow, if the nurse doesn't inform the physician regarding a ECG, it is a crime actually. And whenever there is a critical situations like code blue is being announced, closed loop of communication between healthcare providers is necessary, because every person will be at the patient side and every person will be going for a same task. It is very important that every healthcare professional and nursing professional takes care of individual tasks, so that all the tasks in an ACLS protocol will be horizontally and vertically taken care of. And during thrombolysis and primary PCI, nursing professionals has very important role, because post thrombolysis, the patient needs to be monitored continuously for 24 hours, and initial 6 hours are very crucial. And the patient might revascularize after the thrombolysis, and there can be immediate changes of revascularization in the ECG after 1 hour of thrombolysis, or it can be further deterioration of condition. It could be a hemorrhage somewhere in the body or in the brain. And during a cardiac arrest in code blue, nursing professionals has to take the leadership role to manage the cardiac arrest in their setups, cardiac setups or ICU setups. And incorporation of multidisciplinary staff along with other dietitian, physiotherapists and social workers is very important to take care of the patients suffering from cardiovascular diseases. And last but not the least, health education and counseling of the patient and family is very important, because after initial emergency therapies, the patient goes off or discharges, and patient might not ever come to follow up. It is very important to encourage the patient and the family for regular follow-ups to keep their cardiovascular health to the optimum levels. And the most important topic, that is cardiopulmonary resuscitation, which every nurse should be aware of, and how the patient, the cardiopulmonary resuscitation is taken care of in the ICU setups or in the out of the hospital setup. In the out of the hospital setup, if the if the victim has no response, he can immediately start hands-only CPR where there is no adequate, because ACLS, as per American Heart Association, still says BLS requires hands-only CPR, which has acronym CAB. Compression is the priority. Next comes the airway, and next comes the breathing. And in ACLS and BLS of American Heart Association is very expensive. Like it costs 8,000 to 10,000 in India. But the same, most of the nurses may not be able to afford this AHA accredited BLS and ACLS courses. For that, Indian Resuscitation has come up with their own ACLS and BCLS algorithms for a much pocket-friendly prices for 500 and 1,000 rupees for nurses and other healthcare professionals, which are very important, and everyone can do it. This Indian Resuscitation Council has brought up this criteria based on the Indian settings. The American Heart Association has criteria based on the universal guidelines, but Indian Resuscitation Council has got according to the Indian settings. And it is our only two hands which can save one's life. By this, I end up this topic, And last night, there was a case in emergency where the patient had come with a acute chest pain, and he was in the temple, and the CATS ambulance of Delhi government has immediately deployed the patient from there, Kalkaji Mandir, to Safdarjung Hospital. As soon as the patient arrived, the patient has been triaged effectively, and the patient received in red zone has inferior wall MI. The nurse's responsibility is to identify the symptoms having by the patient and immediately inform the physician so that he can take care of the further treatment modalities as per the protocol. By this, I end this session. Hope everyone has got what I have detailed in this. Thank you.
It's not come, ma'am. It was a really informative session. I'm sure your inspiring speech will enhance our knowledge to greater extent. I believe all the delegates have greater adequate amount of knowledge regarding cardiovascular health. In order to make this session more fruitful, we'll have a question and answer session so delegates and clear their doubts with our knowledgeable speakers. So if anybody has any kind of doubts, please raise your hand. We'll try to clarify your doubts.
Dinesh, Mr. Dinesh has a question. Dinesh, you can ask your question.
Yes.
Unmute ಮಾಡಕ್ಕೆ ಹೇಳಿ ದಿನೇಶ್.
Yeah, very good
Dinesh, you can
afternoon.
unmute.
Yeah, thank you. Sir, it was such an alarming content that we have collected through your slides that you have shared with us and the knowledge that we have gathered. Anyhow, I wanted to ask some few things with you.
Yeah.
So first of all, in which case or condition the need of heart transplantation to be made, is there any alarming signs that we want to keep in mind?
Heart transplantation.
Yeah.
Heart transplantation is a condition where Dr. Ankur would be more authoritative to give advice, because being a nursing officer, I cannot say anything on that. Apart from that, anything to be asked?
Yeah. Another question is here, sir.
Yeah.
So what will be the best suggestion you can give for me to be a better donor of my heart? So the questions which
you
I'm
can
having
enroll in Noto.
Okay.
You can enroll in Noto, which is you can go to the Noto site and you can download a form and you can fill it and give it to the submit to the Noto office, so that every organ can be donated at your own consent.
Thank you, sir. One more. Actually, in recent days, we are seeing that the majority of the death that is happening because of cardiac arrest, even if they are a physically fit person, they are prone to get a cardiac arrest. So what else are the regular checkups that we want to make to know our cardiac health? Is there any routine checkups that we want to make?
Yes, Dr. Ankur has already emphasized, basic ECG is an essential part to see if there is any symptomatic, if the patient has any symptom of cardiac discomfort, then he can go for a ECG initially, and later on for a lipid profile where it includes triglycerides, LDL and HDL. But apart from this, he can consult the physician for echocardiography, where he can get the exact measurements of the heart and the ejection fraction, where the measurements of heart's pumping will be evaluated, and further investigations will be done by the cardiologist.
Okay. Thank
If
you,
the
sir.
patient experiences some chest discomfort, unusual and acute, then he can go for cardiac markers. Like if you go to a emergency, they will initially do a TROP-T test, which is a blood test, which is a kit test. As soon as the kit test becomes positive, then a test, much more effective test, that is TROP-I and CKMB, will be done in the cardiac emergency, where the patient will be further diagnosed and confirmed for a further angiography and angioplasty, where how much blockage is being seen in the coronary arteries. And it is important that nursing professionals should identify which part of the heart. By seeing a basic ECG, you should know which leads are identifiable for perspective side of the heart. Like inferior wall of the heart, it includes lead 2, 3 and AVF. Like lateral heart, it includes AVL and lead 1. And anterior of the heart, lead V1, V2, V3, V4. And these things are very important, so that initially the nurse itself identifies the problem in the ECG, and he or she can alarm the physician, so that he can take into deeper look and identify or further investigate for further treatment modalities.
Okay, sir. Okay. Yeah. Thank you. Sir, once again, I congratulate all the speakers and the organizers for giving such a session. Even I hope even our students, even my colleagues, even everybody, they got such a knowledge regarding the details. Thank you very much all. Thank you.
Thank you.
Are anybody else?
There is one question on YouTube from Mr. Venkat. He says, I have heard that there are less heart diseases in Kerala compared to other states, though they consume more coconut oil. Are there any specific reason for this?
There is no particular data or statistical data according to this, because coconut is a seasonal fruit of Kerala, and from generations Kerala people depend on coconut oil for the edible oils, and it is not like that people of Kerala doesn't have less heart diseases.
Are anybody else have any doubt? Okay, as I
no,
feel
thank
now,
you so much. Over to Ratnadeep and Sneha madam.
As I feel now, nobody have any doubt. With that, we are concluding our first session, cardiovascular health for everyone. And so with this, we will move on to the second session, which is palliative care and update.
So today we have with us an exemplary personality, a charismatic leader, and a renowned speaker, Dr. Bableshawar. Now I'd like to call Ma'am Sneha to give a detailed introduction about Madam. Over to you, ma'am.
Thank you, Ratnadeep. Now it's time to begin our second session on palliative care and update. I would like to give a brief introduction about our next speaker. To begin with, we have with us Dr. Bableshawar, interventional pain and palliative care physician, senior consultant, Rajiv Gandhi Cancer Institute, Delhi, and Ramakrishna Care Hospital, Raipur. To introduce Madam in brief, Madam is an interventional pain management consultant with experience in chronic pain and palliative care for more than 14 years. Madam has organized several conferences, seminars, workshops, and conducted CME program in palliative care and pain management at RGCI. And she is also a certified BLS and ACLS trainer from American Heart Association over last 10 years. And has led many training programs at various reputed hospitals. She has also started Prayas series to spread the awareness on cancer, pain, and supportive care. Madam has innumerable publications at national and international levels. Madam is awarded for Best Poster Presentation at International Conference. Madam also holds membership at reputed domains like Indian Society of Pain, International Association of Study of Pain, Indian Association of Palliative Care and Anesthesiology. There are many more credits adding to her achievements. We are fortunate to have such an eminent speaker with us in today's conference. I request Madam to take over the session. Over to you, ma'am.
Thank you so much, Sneha, for your kind words. Am I audible to all?
Yes, ma'am.
Shall I share my screen?
Sure, ma'am.
I only the host can share the screen.
Ma'am, we are unable to see your screen. Once again, can you share it?
No, actually, I don't have the right to share.
Just.
Ma'am, you can share. Try now, sir. Ma'am.
Is it visible now?
Not yet, ma'am.
So it is showing that only host can share the screen.
Just a moment, ma'am. I'm just checking. 1 second. Ma'am, please try once.
Yeah.
Not happening, ma'am. Ma'am, I'll share from my end. You may just tell me to proceed with the next slide. I'll continue.
It is showing that who can share, only the host or all participants. So only host is
No,
ticked
no,
here.
ma'am. It's not. I don't. It's not there. Just give me 1 second. You're a co-host, ma'am. You should be able to share. Ma'am, I have just shared. You may please continue, ma'am. No problem. You just let me know when to change. I'll change the slides from my end.
So good afternoon, everyone. And I'm really thankful to the organizers for giving me opportunity to talk on this beautiful forum. So my topic is very simple, and it is just to talk on palliative care. So I hope that everyone knows what a palliative care is. And today is the World Heart Day, and everyone has made, the previous speaker has made my job quite easier because of the elaborative talk on the cardiovascular diseases and the need of an hour in Indian global scenario. So next slide, please. Okay. So the newcomers who doesn't know about the status of palliative care in India. So let me just brief you that less than 1% of the India's 1.2 billion population has an access to pain relief and palliative care. And more than 75% of the world's population lives in countries that provide less than half of the morphine needed for palliative care. So this is what is the current status of palliative care in India. So I think that this is also a need of an hour to get aware about what palliative care is and in what patients palliative care is should be integrated and what is the work done by the palliative care services. Next slide. So now coming to the WHO definition of palliative care is an approach that improves the quality of life of patients and their families facing the problem associated with the life-threatening illness through the prevention and relief of suffering by the means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual problems. So optimizing patients' quality of life at any stage of disease. So it is about the incurably ill patients, maybe the elderly, or maybe the dying also. So palliative care is a care which is beyond medical interventions. So many branches are there in the medical fraternity, like the cardiology, physicians are there, pediatricians are there, oncologists are there. But palliative care is the only branch which is different from the other medical fraternities who takes care of those patients who has a life-limiting illness and not only the patients but also their families with a holistic approach. Next slide. So it is a team-based approach and it is the art of medicine which provides us skills to connect more and palliate to ease the patient's suffering. Palliative care takes care of patient and family both. Next slide. So now palliative care team, as we talked about, so what is team consist of? It consists of a palliative care physician and the backbone of the palliative care team is the palliative care nurse. Then the psychologist, because palliative care takes care of the patient in toto as a whole with a holistic approach. The pharmacist who dispenses the drugs and explains how to take it. Physical and the occupational therapist, because rehabilitation is the major arm of palliative care. Nutrition expert, because so many nutrition problems are associated with the patients who are fighting with their life-limiting illnesses. A medical social worker to provide them a financial support to them as well as to their families, and a palliative care certified nurse. So this is what is the palliative care team consists of. Next slide, please. So now I always say that two questions should always come to our mind in case if we see any chronic illness patient who has a life-limiting disease, maybe a cancer, maybe a ischemic heart disease, or maybe dementia, delirium, like that. So how can we use our skills and knowledge to reduce their suffering? And how can we make sure that the society around him knows how to support him? So that should be a community-based approach towards a patient who is fighting with any chronic illness. Next slide. So now whenever we talk about palliative care, the first and the foremost disease which comes into our mind is cancer. So let me tell you that cancer is only 28% global need in the World Atlas of palliative care, and so many other diseases are also associated in which there is a need of a palliative care support. For example, now today is a World Heart Day, so the chronic ischemic heart diseases, non-ischemic heart diseases, cerebrovascular diseases are also, they do also require palliative care support. The lung diseases, degeneration of the CNS disorders, inflammatory diseases, dementia, diseases of the liver, chronic kidney diseases, premature birth and birth trauma, congenital malformations, even poisoning, musculoskeletal disorders, tuberculosis, and even HIV patients. So all these diseases are also there which do require the need of the palliative care and not only the oncology and the cancer patients. Next slide. So now coming to the major goals of palliative care. Palliative care provides relief from pain and other distressing symptoms. So it is the supportive ancillary branch which provides the symptom management to the patient along with the concurrent curative or a palliative approach towards their disease. So it affirms the life and regards dying as a normal process. Next slide, please. Yes. So it intends neither to hasten or not postpone death. So we believe that as we have come into our life pain-free, so we should go also from this world pain-free. So it integrates the psychological as well as the spiritual aspects of patient care. So that is why it is a holistic approach. It doesn't take care of only the physical symptoms of the patient, but also the psychological and the spiritual aspects of patient's care. Will be moving forward and seeing what are the psychological needs and offer a support system to help patients live as actively as possible until death. Next slide. So it offers a support system to help the family cope during the patient's illness and in their own bereavement. So palliative care also teaches so many other coping strategies, not only to the patient, but also their family and friends also. So it is a team-based approach to address the needs of the patients and to individualize their needs and give them a person-centric approach. So if indicated, will enhance their quality of life and may also positively influence the course of illness. So it is applicable early in the course of illness. So we always think that palliative care is for the patients who are suffering from the chronic life-limiting illness, and it is the terminal care which comes towards the end when the patient is approaching towards death. So this idea is should be made clear in every one's mind that the integration of palliative care should be from the time of the diagnosis of any chronic illness, be it whether it is cancer, be it whether it is HIV, be it whether it is congestive heart failure, whatever the illness is, but it should be integrated from the very beginning of the time of the diagnosis. Next slide. So whether the disease is curable or not, being a human being, we should be able to control the symptoms with a person-centered approach. In case if the patient is having pain, nausea, vomiting, fungating wounds, bed sores, incontinence, confusion, dyspnea and breathlessness. So being a human being, each and every person has the right
that along with their normal treatment of the biological disease, these symptoms should also be controlled and make them and to provide them a good comfort care. And these few symptoms like pain, nausea, vomiting, breathlessness are dreadful even in the cardiovascular diseases as well. Next slide. So now coming to the total pain concept. Now you must be wondering that what concept it is. So as it is, the concept was given by Sister Dane Cicely Saunders, who defined the concept of total pain as suffering that has all of a person's physical, psychological, social, spiritual, and financial suffering. So total pain means that to see the patient as a whole in total, but not only the physical suffering, but also the psychological suffering, financial suffering, spiritual suffering, as well as the social suffering. Next slide. So psychological domain is basic communication skills to talk to the patient and the family in a supportive way. Healthcare professionals should be involved in the care. Family, friends, neighbors, colleagues with whom the patient spends most of their time and her time should also be included in decision making and in personalized care. Next slide. Now coming to the social domain are the addressing the social determinants of suffering. It is not that in case if the patient is suffering, so we should just keep the patient in social isolation. So that is not a good idea. So we should provide the social confidence also should be given to the patient, and the problems caused by the gaps in social cohesion around the patient should also be solved. The final solution is a society which works towards the well-being of all its members, creates a sense of belonging, promotes trust, offers its members the opportunity of upward mobility. Next slide. Now coming to the spiritual domain, help the patient to find the meaning and the purposes in life, whether it is a religious belief or it is some other belief, and which gives reason to the life of a patient should always be addressed by a palliative care specialist or a palliative care nurse and the palliative care team. Next slide. So now coming to the objectives, the team discusses the bold recommendations for changing the current cancer care that not only reduces the cost but also improves the patient care. It discusses why the patient deserves open and honest communication and medically appropriate goal setting. Discuss the importance of advocating for pain and symptom management, because maybe the pain and symptom are not important for any other person, but it is important for the palliative care team and for the patient and their caregivers who are suffering from these symptoms in conjunction with their treatments. So discuss the practical barriers to changing the practice and the attitudes of the cancer care providers, and to discuss how to be an advocate for your patients and the field. In case if no one is understanding, so we have to do a patient advocacy and we have to make them understand that these symptoms are also equally important along with the treatment of their biological disease. Next slide. So certain changes should be suggested. The oncologists need to recognize the cost of care, which is driven by what we do and what we do not do. Both the doctors and the patients need to have a more realistic expectations, realign the compensation to value cognitive services rather than chemotherapy more highly, and better integrate palliative care into usual oncology care. That should be the concurrent care should be there, and the need for cost effectiveness analysis and for some limits on care must be accepted. Next slide. So oncologists who receive feedback give less chemo at the end of life. Next slide. Now reduce the fears of abandonment with the better integrated end of life care. So in case if we plan for a good death, won't make death happen, this should be explained to the patient and to the family that talking about death is not a taboo. People who have discussion with their doctors about impending death have less depression, they have a better quality of life, they use hospice more and longer with less CPR and better caregiver quality of life. People who use hospice for even for 1 day lives weeks longer. This is shown by evidence-based studies. Next slide. So palliative care in an outpatient oncology patients allowed the introduction of the palliative care earlier in the disease course. So it should be at the time of diagnosis only, and ease transition from curative to palliative care goals of care over time, and enable the expert symptom management in outpatient setting and facilitate the delivery of quality of cancer care. And same as in oncology, in cardiovascular diseases also there must be the integration of palliative care with the cardiologist to provide them the primary as well as the secondary palliative care with so many other distressing symptoms like dyspnea management, fatigue management, depression, anxiety, and to give them a honest communication and holistic approach towards their patients' symptom management. Next slide. So palliative care allow the oncologist to focus on cancer evaluation, staging treatment, and save time for patient and allow for higher volume practice and increase satisfaction with quality of care delivered. Next slide. So I would like to just conclude by saying that palliative care should not be the business of only the palliative care team. Palliative care business should be the business for all other physicians, all other nurses, and the people who are attached with the medical fraternity. And it is not only for the oncology patients, it should also be for the cardiovascular patients, stroke patients who require a long years together of concurrent care. And the current system does not always work well for sick people. So this is a branch who looks after those sick people who have a life-limiting illness, and not only the patient but also their families, providers, hospitals, or hospitals. And concurrent care is one way to improve care because it sets the medically appropriate goals, allow medically reasonable choices, meet the patient and the family needs. That is why an individualized approach towards the treatment is necessary. Better management of symptoms, improved quality of care, no harmful effect on survival, and possibly positive effect, reduce the ICU and hospital use, lower cost overall to preserve the funds for where it is mostly needed. Next slide. So in the end, I would just like to quote as said by Rabindranath Tagore, the most important lesson that man can learn from life is not that there is pain in this world, but that it is possible for him to transmute it into joy. So that is why the treatment of all these symptoms, whether it is a cardiovascular disease or it is an oncology or it is a CNS disease, but integration of palliative care and the management of symptoms is equally important and a human right to treat their pain and symptoms as well as to treat along with their biological disease. Thank you.
It was really an informative session which has enriched our knowledge. Thank you, madam, for sharing your valuable knowledge with us. And with madam's detailed discussion, I think everyone now have a better understanding of what is palliative care. In order to clear your further doubt, if anybody is having any question, you can please ask to the madam, and ma'am will clarify your doubt.
Okay. Any doubts, participants?
Okay, so I think nobody have any doubt. Madam's discussion was very thorough and detailed, so everybody have a better understanding now. So with that, today we are very fortunate to have Lieutenant Ellie Stella Virginia, retired military nursing service, Indian Army, with us. And I would like to call Professor Ma'am Sneha to give a detailed introduction about ma'am. Over to you, ma'am.
Thank you, Ratnadi. First I would like to thank Dr. Bableshawar ma'am for your wonderful session. It was really very informative session. Thank you, ma'am. Yeah. Next, we have our last speaker amidst us, Lieutenant Mrs. Alice Stella Virginia, retired military nursing services, national faculty, Indian Association of Palliative Care, End Life Nursing Education Consortium, and master trainer. To introduce Madam in brief, Madam is a registered nurse graduated from Military Hospital, Hyderabad, Jhansi. Ma'am worked in military nursing services and Ministry of Health from Sultanate of Oman. She started her services at Pain and Palliative Care Unit at Medical College and Hospital, Kozhikode. Madam has completed several courses in palliative care. She has presented various papers at national and international levels and also organized conferences, seminars, and workshops at international levels. Madam is a certified trainer for palliative care and leads sessions for doctors, nurses, paramedics, volunteer organizations, and students. Madam is also awarded with many appreciations, awards, letters, and so on, adding to her credit. We are honored to have such an inspiring personality with us in today's event. I request Ma'am Alice Stella Virginia to take over the session. Over to you, ma'am.
Thank you so much, Dr. Sneha. And I thank the organization and, of course, the Dean of Care, Mr. Hamza, for inviting me for this session as the speaker. I'll just share my screen. I hope you can see my screen.
Yes, ma'am. Your screen is visible.
Okay. Okay. So I'm going to speak about the role of nurse in palliative care. So today, the World Heart Day. Use a heart for every heart. Yeah, we are using in palliative care our heart for every heart. That's what I want to say. World Heart Day. We have to see. Yesterday I was just sitting and thinking what to write about the heart. So I thought the heart is one thing which connects our head and hands, especially for the nurses. It has all the emotions and always it is eager to know the happenings, what is happening around them. It is active, has attitude and wants to do something actively. And of course, it needs rest to rise more actively. And it needs toning and tries always to keep us updated with the surrounding. So that is heart. So let me come. I have quoted a word about Mother Teresa, what she said. We can't do great things in this life. We can do little things with great love. And to the last, you can see, do everything as if today is the last day of your life and yet do everything as if life will go on for eternity. So in palliative care, when you talk, the role of nurse in palliative care is low-tech and high-touch. Our technology is very, very less in palliative care. We don't use much high technology, but our high-touch, that is very important in palliative care. So just if I say what is palliative nursing, if you show, because it involves the assessment, diagnosis, treatment of the human responses to actual or potentially life-threatening illnesses. And to remember this one thing, that the relationship with the patient and the family to reduce the suffering is the main aim of the palliative nurse. And of course, palliative care is a specialized medical care for the people living with serious illness. It is focused on providing relief from the symptoms and stress. And the main goal is to improve the quality of life of both the patient and the family. We don't keep the family away from the patient. No, both. When a patient is suffering, the same way the family is also suffering. And if we continue it is helpful at all the stages of illness, and so the best provided from the point of diagnosis. Whenever a chronic illness, otherwise a life-threatening illness is being diagnosed, better to start palliative care for the patient to improving the quality of life, helping with the symptoms. And palliative care can help patients understand their choices for medical treatment. A palliative nurse should be genuine, warm, and compassionate. Relationship of a nurse with his or her patient is frequenting a healing relationship even in the face of death. So one thing, remember, it is we nurses who provide much of the care and support to the patient and family, that also throughout the disease trajectory. And we are there for 24 hours with the patient. So we know more about the patient. So a palliative nurse is good in basic nursing skills. She knows how to plan individually for each patient. And she she knows that the patient is going through the most difficult time in life and works always with the patient, family, and the friends. And reassess regularly as change occurs frequently. And the nurse's role is to observe the patient, assessment of the patients and the family's need, evaluation of the results of intervention, and of course, regular reassessment. So as I say, low tech and high touch. Your touch, your eyes speaks a lot than your words. And the nurse is that person who can read the body, mind, and the soul of a patient. You can see here, just my touch. When I was just looking at this patient, he was just saying how long I will be like this. How long I have to lie down like this. Care beyond cure. There is a saying that patients don't care how much you know until they know how much you care. And of course, remember, a smile is infectious. Because the smile on your face reflects on your eyes and voice, even if you wear a mask. So keep a smile always on your face. It heals a lot. So the role of a nurse is important because we are the largest group of healthcare providers. We are the vital resource. We spend more time with the patients, and we are the most trusted of all the professions. And nursing is both an art and a science. So nowadays, when I talk about art and science, I usually say that art has gone. Okay. So in our time, we used to modify the things, whatever we are having in our hand for the use of the patients. Okay. Now everything is available in the market. Commercially, everything is available. So whatever we are getting, we are using it. People are not much bothered about this. So remember one thing, whenever you are, nursing is both an art and a science. That's what I first showed. The heart, that is our heart, connects with our head and hand. So we think to do something, the message is passed to our brain, and after that, it goes to our hand. Then we start doing. So remember this always. There should be an art in our nursing. So nurses have come to understand that it is not enough just to fight the disease, but to provide pain relief, symptom control, improve patients' quality of life, especially at the end of life. So when we talk about a definition of a nurse in a palliative care, she is very supportive. The nurse is giving intensive care, giving continuously, knowing the thing she's doing. She's there always, acts on behalf of the patient, and collaborate with everyone. And of course, the role of palliative care nurse is she's a case manager, she's a coordinator, she's a facilitator, she's an educator, she's an advocate for the patient, and of course, she's a friend to everyone. When we talk about the coordinator, lays between team members. When we talk about any job, we have the team members. So she coordinates between the team members, coordinates the plan and implements the care, and makes contact with the patient and the family and maintains a good relationship. She's a facilitator because she identifies the nursing problems, obtain information, then she plans what to be done and implement the nursing care plan. Main thing is to discuss the care plan with the team and decide how often we have to see this patient. Identify the patient's personal goals also, coping abilities and support systems, and evaluate effectiveness of the plan and modify accordingly. She's the main person to educate the patient and family. More than that, I can say she empowers the patient and family. Monitor and manage patient's status reporting to the doctor. And of course, she supervises and reviews the medication compliance. So when we talk about empowering, to enable the patient and family to care for themselves, like, for example, we teach the patient's family how to make your occupied bed. We teach them how to take care of a catheter, Foley's catheter, how to feed the patient, what to feed, how to do dressing. Many of our patients' family, they does even malignant cancer wounds, they only do the dressing. They take care of colostomy, they take care of lymphedema. So these things we teach the patient and the family. And of course, identify areas where the patient family can be involved with the care, providing information and involve the patient and family to establish a planned care. And of course, encourage whatever they do, maybe very simple things also, we do encourage them and acknowledge their abilities. So as educator, patient and family, we teach them about the administration of medication, how to give the medication, why we are giving this medication, what they have to see after giving the medication, to keep a monitor on the medications, what they are giving, and if they are not giving, why they are not giving. And if there is any side effects to report also. Teach them how to care of the skin, care of the catheters, about nutrition. Basic nursing skills we do teach them. And of course, specialized care like colostomy, lymphedema, malignant wound, many other things. And of course, as educator, she's the one who supervises junior nurses, teaching team nurses, and orientation of new nurses. And not only that, she's an educator for all the doctors, nurses who are coming as a trainee over there, the volunteers, campus students. We empower even the campus students. They do a lot of work for us, setting up the camps. They sometimes even help. They come during their, leave time and all, holidays, they do come to help us. So many things we do as educator, we teach others. Even the layman is being taught as volunteers, we teach them how to care for a patient, maybe for their own benefit, otherwise their neighborhood. Advocate, defends the rights of the patient. See, the ethical issues when we talk about autonomy, beneficence, non-malfeasance, and justice. Okay, so respect patient autonomy, giving truthful information. Every person has a right to take decision for themselves. So we have to ask the patient before we give an injection, why we are going to give injection, whether they want it or not. Advocates immediate needs of the patient, for the family needs, and sometimes helps in dealing with the unfinished business. Business can be many things. For example, I will tell you, one of the patients, when they had come, actually her husband said that her daughter's marriage has been fixed and they don't know what to do. But seeing the condition of the patient, actually we told them better to prepone the marriage. And it happened so, they preponed the marriage, and after the patient, daughter's marriage, within 1 week the patient passed away. Nurses are the physician advocates also. We buffer between the patient, doctor, and the family. We are the change agent. Now, nurses plays a complex role in the management of terminally ill patient and their family. When the patient is with us throughout, right from the diagnosis, and slowly, as the patient transits from one treatment to the other, now the patient is end up with the end of life care, our role also changes. And our relationship with the patient, that is the foundation for our care, and helps to bring about changes to improve the system also. Now, when we talk about supporting the family, assess the family structure, what are the functions, strengths, weaknesses, and knowledge deficits. Everybody will be not knowing everything. So we need to teach them also sometimes how to take care of a patient. Encourage communication among the family members itself. We need to talk to the patient, we need to talk to the family members and tell them how to communicate with the patient, how to communicate, what we should not communicate, what we have to communicate with the patient. The main thing is listening. Sit and listen to the patients. Respect their privacy and accept the coping styles. And of course, conduct meetings to review the goals and decisions. There should be a family meeting where our team also can sit with them to find out if there is any problem, or we can even talk to them about the patient's prognosis. Teach caregiving skills to the primary caregiver and assist throughout the grieving process and of course in bereavement, because palliative care doesn't end with the patient's life. No, there is a bereavement period also where we visit after the patient dies. We go visit the patient's family. Ethical decision making. We can help them. It can be a shared decision also, but we can help them in taking a decision, whether they want the patient to be kept in the hospital or in the hospice, whether they want to take the patient back home. Because when we talk, many of the patient's family, they say, yeah, he said that he wants to die at home. So we can give them a choice, ask them whether if you want to take, you can take. The other support there will be from the palliative care. And balancing the burdens and benefits of each option in terms of quality life. All the time, when we no need of doing many investigation and a lot of interventions, at times, we have to stop doing a lot of interventions. When we know the patient is in advanced stage and the patient is facing the death, there is no use of ventilators. At times, that is why we say we need to communicate with the patient and a family. Let them know how the disease is going, what will happen ahead. And once the curative treatment is finished, rest the supportive treatment, what we will be doing, giving them. And of course, advanced directives also is very good that we need to talk to them. Anytime at a point, the patient is in a very crisis, in an emergency, do you want to put the patient in the ventilator? Do you want to do CPR? These things we have to talk to the patient, the family and the patient. If the patient is conscious, let the patient take the decision. That is very important. Palliative care nursing demands intense critical thinking. Suddenly there is a blow up. Massive bleeding is there. She needs to just take a decision about that. She should have a high levels of mental functioning, making connections with others. Empathy and understanding should be there. No sympathy, empathy. Put yourself in their seat and just think about that. How you will feel if you are undergoing cancer, otherwise any other dreadful diseases. Otherwise, one of your family members is facing such things. How you will feel. So empathy, putting your feet on somebody else's shoes. And of course, understanding what they are going through physically, psychologically, socially, spiritually, and of course, financially also. And the ability to react quickly and effectively in emergency situations. A lot of emergency. Don't think that in palliative care there is no emergency. The nurse's role is very important in palliative care because there will be severe pain, dyspnea, delirium the patient. The patient will have a blow up, severe bleeding will be there. There will be some obstructions. So in that cases, how the nurse is going to take care of the patient. And with the family, of course, explain difficult and complex issues using simple words and concepts. Don't talk your high-tech medical words to the patient and the family. No. Simple in their own language, explain to them. Even if there is a tumor, explain to them what is a tumor, where it is, show them. And of course, respond to the difficult questions, emotions, and statements. They may cry someday, they may get angry. But we have to be there with the patient even if they are angry. Because after some time, the anger will go down, they will come back to ask the question again. So that time we have to respond. And know when silence is the best response. Suddenly someone asks you, one patient is asking you when you're taking rounds, am I going to die? Maybe the patient is not dying and you won't have answer immediately, but your expressions, your silence will give them the answer that you're slowly moving to death. So in some cases, maybe we have to keep silent. For every question, there is no answer. Remember that. Support families taking ethical decisions. Ethics itself is a big, broad subject. I'm not going to that, but we have to support the patients. I still remember one parent, a child was hardly 5 years, who was facing cancer, was almost, first they have already finished their chemotherapy, and there was recurrence. Okay, so when he had come back, he said, I told my family that I'm not going to take him for any treatment now. So actually I appreciated him. I said, you have taken a very good decision. And I asked him, why you took this decision? And he said, I saw my child suffering in the first treatment of line of treatment itself. He was suffering a lot. But I thought maybe with that treatment he will be cured. But no. With all the chemotherapy side effects and other things, it went on. And now I know my child is not going to be cured. So as far as possible, I want to give him comfort, good quality of life, and I want to give him a peaceful death. And when he said, tears were rolling from his eyes. And I told him, it's very difficult to take such a decision. But I do appreciate, because you wanted your child to be comfortable. Actually, he doesn't want all that tubings and everything on his body. You want him to move peacefully. He just asks only one thing, pain relief, that's all. And be open to their need for communication. Anytime they come to you asking any question, be open to them. In the sense, be there for them. Okay, maybe if you don't have time, just tell them, see, I'm busy with doing the procedures. Okay, after I finish it up, we will sit and have a talk. Don't neglect them, whether it is a patient or a family. So nurse, I believe there is no richer experience in nursing than to be allowed to walk with a patient who is at the end of life. And of course, live life when you have it. Life is a splendid gift. There is nothing small about it. And there is no situation where nothing can be done. There may be a limit to cure, no limit to care. So this, you can see this child sitting. Okay, this was in our OPD. And he was refusing to come even inside. And you can see my eyes somewhere and looking, and he is looking at me. Well, you know, there was a aquarium over there. And he was very fond of the aquarium too, but not much, what to say, friendly with everyone. Okay, so I was just explaining to him about it. No? And there is one more photo where I've given one laddu. Okay, I gave him in his hand. Okay, so look at the mother's face. She's smiling. Okay, we had a nice talk. And this, what you are seeing, this is a poem of a nurse. Given, it was presented to me by one of my patients when I was in army. Just I'll go through. The world grows better year by year because some nurse in her little sphere puts on her apron and smiles and sings and keeps on doing the same old things, taking the temperature, giving pills to remedy mankind's numerous ills, feeding the body and answering the bells, being polite with heart that rebels, longing for home and all the while wearing the same professional smile, blessing the newborn's babes, first breath, closing the eyes that are still in death, taking the blame for many mistakes. Oh dear, what a lot of patience it takes. Going off duty at 7 o'clock, tired, discouraged, and ready to drop, but called back on special at 7:15, with woe in her heart which must not be seen, morning and evening, noon to night, just doing it over, hoping it's right. When we lay down our caps and cross the bar, oh Lord, will you give us just one little star to wear in our crowns with the uniform new in that city above where the head nurse is you. Thank you.
Wow.
That was the addictive and educative session, ma'am. And I'm sure delegate has enjoyed your session thoroughly. So as you have speak about the various part of palliative care, I'm sure that some person might have some doubt. And
Yes, sure.
if anybody is having any doubt, please raise your hand. As I can see, Mrs. Jyoti ma'am has raised her hand. Yeah, ma'am, you can ask your question. So ma'am will clarify your doubt.
Hello.
Hi, ma'am. Good afternoon.
Good afternoon.
Happy World Heart Day, ma'am.
Thank you, same to you.
Ma'am, it was a very wonderful session. It is a palliative care. It is my two doubt it is there, ma'am, whether palliative care is required in a donor's family. So once the person has donated his heart, like after his death, organ donation, whether the palliative care is required for the donor's family.
Yeah. If you ask me, it needs. Okay, because leave the physical. See, leave the physical, that psychosocial and the spiritual.
Yes.
Okay, that will be a great support for them.
Yes.
Okay, because they will have a lot of things to tell you. Okay, many times this happens. The donors will be giving, nobody's bothered after some time. Okay,
yes,
but if you do a home visit for them, keep them, talk to them, they will have something to talk about that.
Yes,
about that person. Okay, so you can give palliative care. There is nothing wrong in that, because especially psychological support. See, they must have taken a decision to give the donate and all that is there, but still think on from our side. Just you put yourself onto that.
Yes,
sometimes it takes, because when brain death happens, many of them nowadays they are donating their organs, right?
Yes,
okay, brain death. So brain death is only happened now. The patient has not died. So, but they have taken the decision of giving the organs.
That is my second question I'm going to ask, ma'am. The second question, as we know, like euthanasia, right, ma'am? Euthanasia.
Yeah.
Like mercy killing. So for that also, we are not we required of palliative care, right, no, ma'am?
See, euthanasia is not allowed in India. One thing.
Yes.
Very right. Okay. And you know very well, you and me, we both know, if it is allowed in India, what is going to happen?
Yes.
Okay. So I can't support it. Okay.
I can't not following euthanasia, but it is in both cases it is required of this palliative care, right, no, ma'am?
Euthanasia. Somehow donors, of course, because they are donating. Euthanasia is something that we are taking over the life.
Yeah.
Okay. So I won't tell that palliative care. In other case, I can tell that someone has to sit and talk to them about it. Okay, yes, why they want to give off their life. That we can do. But as a palliative care, I don't say. Because in palliative care, we are against euthanasia actually. Because we help the patient in end of life care right from the beginning. If the patient is also going through many other problems, we try to control their symptoms and slowly let them move to the head and have a peaceful death. That's what quality of life is improved, and that's what we are focusing on to. Okay, euthanasia is not, I just want to run off. Okay, at least we can talk. We can say, we can make some counselors to talk, other social workers to sit and talk why they want to do it.
Yes, ma'am. Thank you so much, ma'am.
Welcome.
Thank you. Thanks to Sneha, ma'am, for organizing a good session. Thank you, ma'am. And thank you all the speakers.
I think one more question is there from Shatrughan Parik.
Sure that the detailed discussion has cleared the doubt of Mrs. Jyoti, ma'am. Now I can see Mr. Shatrughan have some doubt. So you can please ask your doubt. Ma'am will help you to clarify the doubt.
Good afternoon, ma'am. Thank you for a beautiful session. And I just want to ask that we know that the euthanasia and palliative care both are the different aspects, but somehow at the end of life care, they are interrelated. Because at the end stage, some people want to just discontinue their life.
Discontinuing the life in which sense you are saying?
Because due to the increased sensation of the pain and like that. So is there any interrelationship between the euthanasia and palliative care?
There is no relationship between euthanasia and palliative. Palliative care, if the patient is having pain, we try to reduce the patient's pain using analgesics. See, if you use proper analgesics, that is WHO ladder, proper analysis for the patient, we can reduce the pain of the patient and the patient won't think of dying. Okay, actually, because the pain is not reduced, we are not doing anything for the patient is thinking of dying. Patient doesn't want to live the life. Okay, so the thing is, what you have to do is, as a palliative care physician, nurse, whatever it is, if you have a palliative care, see that the patient's pain is reduced. He's able to sleep. He's able to take his food if there is no other problems. Most of the time, the pain is one thing which the patient faces very badly. And when the pain is not reduced, see, if you ask me also, if my pain is not reduced, I will also think better to die. Why to suffer this pain? Right or no?
Yes, ma'am.
Okay. But if somebody reduces my pain, I will be happy. I will slowly only die because my pain is reduced. Okay, so euthanasia is not that this one. Euthanasia, why the people are thinking of dying is maybe because the pain is not reduced. And once we talk about euthanasia is the other thing. People just want to die. They doesn't want to face this world, and they go for euthanasia. Anyhow, thank God it's not in India.
Yes, ma'am. But nowadays, more debate is going on the passive euthanasia in India because Aruna Shanbag case. After that, passive euthanasia is more in discussion in India.
Discussion in India. See, actually, from palliative care itself, there was one advanced directives and talk about this end of life care. A lot of things have happened. Okay, in the Supreme Court and all we could. Okay, so all are thinking about that advanced directives now.
So, ma'am, we can add things in a palliative care that we have to counsel the patient that just kind of developing a hope of life, so they never go for the euthanasia.
Yeah, we can talk to the patient about their problems. See, we always talk to the patients only about their physical problems. Okay, more than physical problems, they do have psychological, social, and spiritual and financial problems. But how many of us we talk to the patient about these things? And really to say, the patient actually wants us to talk about their psychological problems to other problems other than physical. Okay, that is one thing. And second thing, anytime the curative treatment is finished, we say nothing is there to be done more, you take home. Okay, see, a patient who is with a rice tube and a patient with a for urinary catheter, a lot of things has to be done for that patient. He's going to be there on the bed for a long time. It's not that today he has a cancer and they are going to die tomorrow. No, there's a way to go. But how many of them are getting a palliative care in their place? That is very important. So our aim should be that each and every institution, every nook and corner of India, palliative care should come. Every hospital should have a palliative care where they can give OP, IP, and home care visit for the patient, because all the patients, maybe many of the patients will be in the village. Okay, so bring up your organization, make a voluntarily this one, so that at least they will get a palliative care in their own place when they are in the deathbed and when they cannot come to the hospitals.
Thank you, ma'am.
Thank you. Welcome.
Okay, so I hope that clears your doubts, sir. So now I can see the Professor Ma'am Sneha has also raised her hand. So ma'am might have some question. Please, ma'am, you can ask your question.
Good afternoon, ma'am.
Good afternoon.
Yeah, ma'am, I have a simple question to you. Whether this palliative care is somewhere related to rehabilitative care?
We have rehabilitation. See, in palliative care, we talk about rehabilitation also. Okay, so for example, rehabilitation in the sense, I will tell you, we have patients who are paraplegic. Okay, even cancer patients also. Okay, so whole life, how long they are going to live, no? They have a lot, their lifespan will be more. Okay, so in such patients, what rehabilitation, they won't be able to go for work under. What we do it here is we conduct camps, we teach them how to make some ornaments, otherwise umbrella, this one, medicine cover, and these things, many things are there. Okay. So that is a rehabilitation for such patients because they earn something. They make this is sold in the market and they earn something. This is also a rehabilitation. So
Okay,
simple things we can do. Yeah.
So whatever they earn out of their selling, so with that amount itself, they utilize it for their betterment. Is it like that, ma'am?
For them, see, even I will just tell, in 2008, somewhere only, first we started a footprints over here in Calicut Medical College, footprints. Okay, in our palliative care. Okay. So when the patients had come, most of them were paraplegia patients, 1 or 2 were cancer patients, long running. Okay. So they were taught many things to do. Okay. Some handicrafts they did. Okay. Someone, they were doing this crochet work and all, umbrella, many things they were doing. Okay. But after these things were sold, and I still remember one patient to whom I spoke, he said the first time when he got 10 rupees in his hand, tears started flowing. He said, now I need not ask anyone money. I can make money. Even the 10 rupees is very important for him. Maybe he want to buy a chocolate or a biscuit for his child. Okay. So rehabilitation, when we talk in our sense, like in the medical profession, rehabilitation, many things are there. Okay. But this is also one type of rehabilitation. And we teach the family, even the patient, we teach them how to take care for themselves. Some things they can do it. Okay. So that is also one type of rehabilitation.
Thank you so much, ma'am. Thank you.
Welcome.
Okay. So anybody else have any doubt? Please raise your hand. Okay, so I don't think anybody is having any other doubt. So as our question and answer session comes to an end, I will conclude this session and I'll call Miss Naina DS, SB College of Nursing, lecturer, Department of Psychiatry, for word of thanks.
I will just interrupt. Ma'am, thank you so much for your wonderful session. Really, it was very informative. And I hope many of us have enhanced our knowledge through your talk. Thank you so much, ma'am.
Thank you, Mr. Ratnadip. Good afternoon, all. I deem it a great honor and privilege to propose a vote of thanks on this memorable occasion. There are many reasons to be thankful for. Today is one of them. As we have completed our national conference on World Heart Day, I would like to express my sincere gratitude to all the delegates for attending our program. Resource person for imparting their knowledge, talent, and skills to all participants to make this event successful. First and foremost, I would like to thank Dr. M.K. Ramesh, Honorable Vice Chancellor, Rajiv Gandhi University of Health Sciences, Bangalore. Thank you, sir, for your valuable words. I extend my gratitude towards our Honorable Chief Guest, Professor Dr. Bimla Kapoor, Chairperson, Committee of Experts, National Nursing Midwifery Commission Bill 2020, former Director IGNO. Ma'am, it's our privilege to have you as a chief guest in this conference. Your presence make our conference successful. Thank you, ma'am. A special thanks to Mr. K.V. Hamza, General Secretary Dinip Care, for accepting our invitation and for being here with us today. Thank you, sir. I would like to express my deep sense of appreciation to Dr. Ankur Chikara, MBBS MD, Assistant Professor, Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. Sir, it's our privilege to have you with us in this conference, which was really thought-provoking and interesting session. Thank you, sir. We are grateful to our resource person, Mr. C. Deshant, Trauma Nurse Coordinator, Safdarjung Hospital, New Delhi. Sir, it was a really informative session which was enriched our knowledge. Thank you, sir. We extend our heartily gratitude to Dr. Bableshawar, Interventional Pain and Palliative Care Physician, Senior Consultant, Ramakrishna Care Hospital, Raipur. Ma'am, thank you for accepting our invitation as a resource person. Your session was so meaningful and educative. Thank you, ma'am. I extend my heartfelt gratitude to Lieutenant Alice Stella Virginia, retired military nursing service, Indian Army, National Faculty Indian Association of Palliative Care. Ma'am, it was impressive and knowledgeable. Thank you for sharing your valuable thoughts. Thank you, ma'am. And also I would like to thank our chairman and managing director of Little Flower Group of Institution for your encouragement and support. Our heartfelt thanks to program coordinator Mr. Suresh TP, Secretary DINIP Care for coordinating throughout the program. Thank you, sir. Our sincere thanks to organizing chairperson Professor Sneha Borgai, Principal SV College of Nursing, for a beautiful organization of the event. Thank you, ma'am. I would like to thank Professor Renju Arvi, Principal, Little Flower College of Nursing, for your constant support and motivation. A deep sense of appreciation to our administrative officer, Mr. Manjuna Jairam, for his uninterrupted support throughout the program. I take this opportunity to extend our heartily gratitude to all delegates who have registered there in conference, even despite of your busy schedule. Hope this conference was helpful to you. We thank you all. I would also like to thank all the teaching and non-teaching faculties of SV and Little Flower College of Nursing, and also I'll gratitude to our technical head, Mr. Manoj, and facility team who has directly and indirectly supported for the success. Thank you, everyone. As all is well when it ends well. With this, I concluding my vote of thanks. Now I hand over the session to Mr. Ratnadeep. Thank you.
Okay, so as our session comes towards an end, I would like to know from Mr. Hamza if he has any input to put on today's occasion. Over to you, sir. Hello, Hamza sir, are you there? If you want to add something, sir, please. Okay, so I don't think Hamza sir is here with us. So I again want to thank Miss Nayana for the wonderful welcome speech. And I want, I would like to have the attention of all of you, please. In order to receive your electronic generated certificate, you should fill up the feedback form. So you will receive the feedback form in your registered mail ID, and you fill it, and you will receive your electronic generated certificate within next 7 days or within a week. With this, I would like to thank all the dignitaries, all the delegates for your constant support, for your constant enthusiasm, and for your constant motivation, which makes today's session very fruitful and interactive. Thank you all. Before concluding today's session, I also want to know if anybody have any doubt. So still time is there. So if you want to ask, you can please raise your hand. So if anything is there, we'll clarify the doubt and we'll conclude today's session. Please. Okay, so I don't think any anybody have any doubt. So all the participants of today's in Zoom meeting and in through our YouTube channel who has joined today, everybody will receive electronic generated certificate. Thank you all. Thank you for your constant support. Thank you.